So Parag, I'm
Yes.
also supposed to join another meeting of IFS. So I
Okay.
may leave after a while.
No problem. No
Please
problem.
excuse me for that.
Sure, sure, sure.
Sure. So, hello and good evening, everyone. It's again a privilege and an honor to be here presenting the second day of this certification course by FOGSI ICOG on infertility. We have with us, this has been done under the able leadership of Dr. Jaideep Tang, President FOGSI, Dr. Madhuri Patel, General Secretary FOGSI, Dr. Parul Kotrawala, Chairperson ICOG, Dr. Sheila Mane Madam, Vice Chairperson ICOG, and Dr. Sarita Bhalerao Madam, Secretary ICOG. The convener for this series is Dr. Parag Binewale, Chairperson elect ICOG, and Dr. Charmila, Vice President FOGSI and GCM of ICOG. And we have with us this entire scientific program has been curated very nicely by Dr. Madhuri Patil Madam. She's here at the moment, and along with Dr. Fessy Louis sir and myself. The We are very good coordinators for the program. Dr. Srishti did very nicely yesterday. Today, Dr. Samidha Dalvi will be doing, and then tomorrow is Dr. Sandhya Mishram. So, yesterday we discussed all the basics of the program, and today is the second day where we are going slightly in a better, in a little advanced mode. So, we shall be talking about the surrogacy, about what are the various factors for recurrent implantation failure, uterine factors, embryonic factors, immunological factors, and we shall also be having use of adjuvants which have come up in a big way of late. We shall be having a panel discussion on that, along with PRP, stem cell, and how does paternal aging, we have been talking only about the maternal aging, but also the paternal aging, how will that affect. So may I request Dr. Parul Kotlawala sir here to give his address to the for the meeting. Yes, Parul sir.
Well,
Mhm.
yes. Thank you, Minu. Yesterday was an excellent program, and I'm sure people will really learn something more today. Yesterday was basics, and now you are moving on to more advanced things. So let us move on with the program. I am always there with this program, and I may go off in between, may get back. Please excuse me for that. Thank you. Parag, you can take over from.
Sure. Yeah.
Thank you, sir. So, may I request Dr. Parag Binewale, ICOG chairperson elect, to say a few words.
Yeah. Thank you, Minu. Good evening, all. I bring greetings from ICOG, and it's indeed a pleasure to welcome everybody on the second day of certification course in infertility. At the outset, I must appreciate efforts put in by the conveners, Dr. Minu Agarwal, Dr. Madhuri Patil, and Dr. Fessy Louis, and of course, our young uh, colleagues who are managing this program, Srishti, Samida, and Sandhya. ICOG always tries to do something, and the certification courses were started during the COVID times in order to have an interaction with the fellows members and members of FOGSI in general. So before we start the pre-test, I hand over back to Dr. Minu and Dr. Madhuri for a recap of yesterday, and then we'll start with the pre-test. Thank you.
So, may I request Madhuri Madam to just recap yesterday's program, and then we will go ahead with the prayers and the pre-test both. Thank you.
So yesterday, basically, we did the basics of infertility. So we started with the role of ultrasound in infertility, where we looked at the role of baseline ultrasound, wherein we need to look at all the pathologies that could be identified, the ovarian and the ovarian reserve, and how we can then further investigate the patient depending upon the primary findings. We also looked at how 3D ultrasound has now can replace hysteroscopy, and because we saw how well we could identify. And this talk was given by Dr. Sonal Panchal. Then we had Dr. Padma Rekha Jirge, who discussed how we can choose our doses of gonadotrophins. depending upon the ovarian reserve. And here we discuss that basically we choose depending upon the AMH as well as the antral follicular count. We do not really take FSH into account because we know that FSH is very late to show changes with decreased ovarian reserve. So basically what we rely upon is the age, AMH, and the antral follicular count. And then the dose should be further amended for the BMI of the patient. The third talk was on semen analysis, where we discussed why semen analysis is important and why it should be the first test to be done in an infertile couple, because you investigate the entire the female and then you realize that the male partner is azoospermia, and therefore semen analysis should be the first test. We looked at how the semen should be collected and what are the different parameters that should be looked for, and also what are the newer things which were being added in the 2021 manual. Then we had a talk by Dr. Charmila, who looked at the indications, and all of us know that IUI should not be done basically in patients who have tubal block, or in those patients who have a severe male factor, and who have a grade 3 or 4 endometriosis where the tubes can be affected. But it is effective in all the other patients, especially more so in patients with unexplained infertility, and in those patients who have mild male factor infertility and probably in stage 1 and 2 endometriosis if the age is more than 35 years, and also in those patients who have ejaculatory or erectile dysfunction. We should not do more than three to 4 cycles of IUI, because it has been seen that after 3 to 4 cycles of IUI, the success rate of with IUI is very, very poor. Then we had Dr. Raki Singh, who looked at the various ovulation induction protocols. So I think we should always begin with basically depending upon depending upon the age and the ovarian reserve, we need to decide what treatment should be offered to the patient, whether it should be just timed intercourse, whether it should be IUI, or it should be an IVF or ICSI. And all this will depend upon the age of the patient, the duration of infertility, the cause of infertility, and the success of any IUI basically also depends upon what type of sperm preparation we are using, what type of protocol we have used, as well as timing of the IUI. When we talk about ovulation induction, we have to use the oral ovulagents. When we talk about oral ovulagents, letrozole is first line of treatment for PCOS, whereas for all other patients, clomiphene citrate is the first line of treatment. If they fail to respond, that is, they have either resistance or they ovulate but fail to conceive, that is, they have failure, then we need to go to second line, wherein in PCOS, lifestyle modification is very, very important. And then if they don't respond, depending upon the LH levels as well as the DHES levels, we could use either dexamethasone or progesterone or estrogen in the second half to suppress the LH levels, go to gonadotrophins. Laparoscopic ovarian drilling was also considered as the second line of treatment, and it's more effective in patients who are basically thin and have high AMH value. But today, according to a lot of evidence, we do not really consider that. And if everything fails, then we need to go for IVF, wherein if a patient has got failure or is failure, then we need to probably, if she's not been investigated thoroughly, then we need to expand the investigations, what we have done to arrive at a diagnosis. And if everything has been done, then gonadotrophin therapy with IUI or IVF is the line of treatment. Whereas in metformin can be added in those patients who are obese and who have insulin resistance. Inositols do not have that much of evidence still to be used. In the non-PCOS, basically, we need to treat patients with who have resistance or failure with gonadotrophins, and if they do not respond, we need to then go in for IVF. So if you look at the success rate of an IUI procedure, when we do it with tablets tablets, it's basically only about 10%. And when we use gonadotrophins with IUI, it is about 15%. When we talk about, then Dr. Meenu Agarwal discussed about the monitoring. So when we talk about the monitoring, I would basically divide it into three parts. One is the patient's initial parameters, where we do the baseline scan, where we have to rule out any ovarian and uterine pathology, and also do the antral follicular count. And we do the baseline hormonal levels for the ovarian reserve. And if at all, and as well as we do the thyroid profile and prolactin levels. And only if required, we need to look at the androgen levels in PCOS women. And depending on that, we can choose the method as well as the drug of choice for ovulation induction. Then the second part is the ovarian response to ovulation induction, where we have to determine the response to the drug, determine the dose and length for which the gonadotropin therapy should be given, the optimal time for giving the HCG. We have to then confirm that the ovulation has happened. And then at times, ultrasound is very helpful in identifying those patients who are not responding to the treatment you have given, or those patients who have hyper-responded. And after completion of therapy, basically, we need to look for complications of ovulation induction. And if the patient has missed the cycles, we need to confirm the pregnancy. We have to rule out multiple pregnancy as well as late onset OHSS in some patients wherein we have got more than 3 to 4 follicles in a non-ART cycle. And we also discuss about in which patients luteal phase support should be given after an IUI. So basically, if you look at the evidence, after oral ovulations really do not require luteal phase support, but all patients taking gonadotropins require luteal phase support. But we do give empirical luteal phase support even with oral ovulations, because it has been seen that clomiphene citrate also at times can suppress the LH, because it also occupies the estrogen receptors in the brain. And therefore, some of these patients who have low progesterone levels, that is, they have progesterone levels less than 15 nanograms per ml on day 7 after the ovulation, also would require progesterone supplementation. And this can be manifest in patients because they might get early periods, or they might even get their menstrual cycle earlier than 14 days after ovulation. And then we had a very good panel on ovulation induction, where we discussed the various points regarding ovulation induction in a woman with PCOS. And it was very well conducted by Dr. Sujata. So if there are any difficulties, you could post it in the chat box, and I would, or anybody, all the other faculties would answer the questions. Thank you.
Thank you, Madhuri Madam, for this nice recap. I think Dr. Sheila Mane Madam is also here. If she, are you there, Madam?
Ma'am, she is not there.
Meenu, let's start with the pre-test now.
Okay. Nilima, can you put the pre-test in the chat box? So for everyone who has been sending messages yesterday also, all the
Ma'am,
recordings.
Sunita madam, sorry to interrupt you, ma'am. Sunita madam is joined. Ma'am,
Yeah.
Okay.
Jignesh, please speak. Madam post.
Sunita, you can unmute yourself. Yeah. Welcome.
Hi. I'm so sorry.
Can we have Dr. Sunita's?
No need of my CV, beta. Can we
Yeah.
stop that?
No.
And
So, yes, so it's my privilege and an honor to introduce Dr. Sunita Tandulwarkar. Although I know that she does not need any introduction to this crowd who's here. She is the head of the department, OBGY and IVF endoscopy.
already we are late because of me.
Okay.
I'm sorry.
Okay,
No
no
need,
problem.
beta. Your love and love of everyone is enough. This is so much of an academic. So I don't want to take a single minute.
See the president-elect FOGSI. So let me coming here, and we are looking forward to the huge installation, your huge installation in Mumbai next year. So everybody should register for that AICOG.
Thank you, Meenu. Thank you so much for making me a part for such a beautiful initiative, which is so thoroughly academic. Nowadays in webinar, the attendance is like 20, 30. I see 168 people have already logged in. So probably this is the after Pravaha, maybe one of the most academically enriched program. People like it. I'm saying after Pravaha, I'm sorry, but because Pravaha has reached to 11,000 registration now. But thank you for making me a part. And at last 2 days, I'm little bit in a mess. Many people are calling me why you left the group. I have not left any group. I love you all, but I take an opportunity to all the leaders who are in this group to tell them that I was just changing my mobile and I logged out. Because including Shanta Kumari, I received a phone call from everyone. Why are you leaving the groups? So thank you so much for making me a part of this wonderful program which goes on. And I suppose this is a 3 days Yemi. I can see even Sheila along with Parag and Madhuri. Whenever there is a high academic, Madhuri Patil has to be there. So looking forward to meet you sometimes personally, all of you. And I invite you all to Pune for our Aspire conference too. Thank you.
Thank you, Sunita.
Thank you very much for these kind words. Yesterday we had over 300 delegates who joined in, so we are still waiting. So they will be joining in now. And thank you very much for your nice words and starting the Star Pravaha series and other so many activities that you have started, and we are really learning from you and getting inspired by you. Thank you very much. Thank you. Thank you.
Minu, just one word. I would like to thank Dr. Sunita for accepting to be there as a chief guest. And I know this subject is very close to your heart, and none other than you, other than you can be a chief guest for this. So I'm traveling, so I'm a little late. So I joined now, but I wish all the best, Minu. Very well planned, and you have stalwarts with you like Dr. Madhuri Patil, and you have framed the program very well. I wish all the best, and thank you all for being there. Thank you.
Thank you, Sheila ma'am. Thank you. Thank you very much. Thank you. So, can I request Nilima now to please post the pre-test? So we have 10 minutes for the pre-test, followed by we will start with the first lecture after that.
Yes, ma'am.
So the pre-test link will be shared in the chat box, and you can fill up the pre-test, log into pre-test link and fill it up. Also, many people were asking yesterday, they can log into ICOG website in about a week's time, and all the recordings will be available for about next 2 or 3 days, and you can watch them. And if there are any questions, then you can either put them in the chat box now, or later maybe you can message to the faculty and they can reply to your question answers, but better to put in the chat box now. That will be better.
Would anybody be giving us a little bit of timer, say 1 minute left or something like that, Madhuri?
Yeah,
Yes,
no,
yes.
there'll be a watch over here which will show the time.
Okay.
Yeah. So there's a timer here you can see on the right-hand corner. So a
Okay.
similar thing will be there when you're talking down.
Okay.
And the chairpersons will also probably tell you if you're exceeding your time.
So it's better to know so you can just speed up and finish it off.
Right.
I've kept it short, but you never know.
So you'll see the timer down below your presentation.
Okay.
The time is over. Has everybody already given the forms, Nilima?
Yes, ma'am.
Yes, ma'am.
Okay. So we will now go ahead for the first session of second day, and it's my again a privilege to introduce the chairpersons for this session. We have Dr. Manoj Chelani sir. Manoj sir, are you there? We have Dr. Chaitanya Ganapule. Chaitanya, are you there? And we have Dr. Shweta called Shweta, I can see over here. Yes. So Shweta is from, yeah. Can you just show the CV of Dr. Shweta? Okay. So Shweta is the director of Nirmay Care Women's Center. She is practicing infertility and at Indore, and she is with ISAR for very, very focused, very passionate infertility and IVF consultant. And she has a lot of things to her credit. She just received the Dronacharya Award by ISAR recently. That was in 2023 in ISAR, Bhopal. She has many publications and many editorial headings to her credit, and she has organized many conferences and a lot of organizations that she has served. She has been the secretary of Indore OBGY Society, joint secretary and treasurer, managing committee member, and executive member of Maharashtra of MP ISAR. So, Dr. Shweta Kaul, you may please introduce the first speaker, and in the meantime, once we have the other chairpersons, I will introduce them.
Thank you, ma'am. Thank you for the kind invite. I'm so happy to be here. And it is a proud privilege to introduce the first speaker, Dr. Nalini Kaul Mahajan, whom I have been silently observing and admiring since more than a decade. And Dr. Madhuri is also here, my teacher. So, Dr. Nalini, ma'am, is Director of Mother and Child Hospital, Scientific Director, Senior Consultant in Reproductive Medicine, and Fertility Fertility Clinics. She was the founder, President of Fertility Preservation Society India, President Asian Society for Fertility Preservation, BOD International Society of Fertility Preservation, Editor-in-Chief, the Onco Fertility Journal, Chairperson Reproductive Endocrinology of AOGD, and Chairperson Public Awareness PCOS Society, and Convener Education Committee IFS. And I welcome you, madam, for your talk. And we are so happy and privileged to have you here.
Thank you very much, Shweta. Many of these posts, I don't know where this CV has been pulled out from. I have long gone way past them, but for whatever it's worth, I'm still the director of Mother and Child Hospital and the president of the Asian Society for Fertility Preservation. So I've been asked today to speak on, okay. Can stem cells and PRP rejuvenate the ovaries? And is my screen visible?
Yes,
Yes,
it is.
All right. Okay, so the first question that really arises out of this is why do we need to rejuvenate the ovaries? And can we rejuvenate them? And if so, Can PRP and stem cells help? And this is what we'll talk about shortly in these 15 minutes today. So why are we sort of so seriously looking at ovarian rejuvenation? Because it is estimated now that 3.7% of the women worldwide are having a decreased ovarian reserve, and we know that women are delaying their pregnancies, and age adds on to the ovarian insufficiency, and women are finding it harder and harder to get pregnant. Also, there is a whole group of young women where we have an unexplained premature ovarian insufficiency. Is it the environmental factors? It is oxidative stress? We don't know, but this group is getting larger and larger, and we are struggling with them, trying to help them to get pregnant. Now, what happens in a failing ovary? There is loss of functional integrity. There is collapse of the ovarian function. The primordial follicles are not available for recruitment. The ovarian niche functionality is affected, and it is unable to support the proliferation and differentiation of granulosa cells. So all in all, we don't have any oocytes or follicles recruited within the cycle, or very minimally recruited, and that is why pregnancy becomes a problem. So what is the rationale of rejuvenation, given that we know that the ovary has a finite number of eggs, and this is what we have been taught all along? But it is now believed that 75% of POI patients may carry residual dormant primordial follicles in the ovary, or very small embryonic-like stem cells, and these perhaps, if activated, have the capability of getting into functional oocytes, which could be used to attain pregnancy. And a number of growth factors have been shown to be important for this primordial follicle recruitment, maintenance, and ovulation. And since we have identified these factors and where these factors are available, perhaps we can get these primordial follicles, which are lying silent, to get activated. So this is all what regenerative medicine is all about. You try to restore form and function of the tissues or organs through biological processes. And the two processes which are clinically applicable at this point of time are stem cells and the platelet-rich plasma. We do have a lot of ongoing research on tissue engineering, biomaterials and scaffolds, gene editing, but they are not yet clinically applicable. So let's talk about the two that are. We start with stem cells. They are what are called the magical cells. They have the ability to self-renew. They have plasticity. They secrete enzymes, cytokines, and proteins, which allow for repair and replacement of damaged cells. They can activate dormant cells. They are immunosuppressive in nature, but perhaps the most exciting quality is their ability to home into the niche. Now, what are these stem cell niches? They are the perivascular compartment around the stem cells, and they controls the biological characteristics of the stem cell via the immune and the vascular system. So they regulate proliferation, migration, and differentiation of the stem cells. So we have various types of stem cells which are in use. You have embryonic stem cells, we have bone marrow stem cells, adult stem cells, and cord blood stem cells. But perhaps the most used and perhaps worked on are the bone marrow mesenchymal stem cells. They have the greater potential of proliferation, they have multidirectional differentiation, they are more genetically stable and therefore more in use and also easier to prepare and identify. So what is done is aspiration of the bone marrow is done and the cells are separated. Please remember that in 1 ml of aspirate, 6 million cells can be isolated, but of these, only 0.001% to 0.01% are really the mesenchymal stem cells. And the International Society has set up certain identification criteria, but we don't have time to go into that. Now, these cells are injected either directly into the tissue or there is a delivery through the blood vessels. How did we recognize the value of stem cells in ovarian failure? Well, the first as usual, as is true for all most scientific breakthroughs, was reported by Sanders. And what he found was that in women who had bone marrow transplant post their total body irradiation, they had natural conceptions. Now, this was very interesting because, the ovaries are completely ablated with the TBI. Now, similarly, there are other people who followed and again showed similar results, that women who had bone marrow transplants went on to have natural conceptions. So the reason for this was that there was the homing of these bone marrow mesenchymal stem cells, and they could restore the function of pre-existing undamaged follicles which were within the ovary, leading to restoration of ovarian function. Now, this was further proved by animal studies where not only fertility restoration, but live births were also documented. So it was a huge major breakthrough. So how do mesenchymal stem cells ameliorate POF? Well, most of it is through their secretome. What they have is a paracrine effect. They induce angiogenesis. They are anti-apoptotic. There is an immune modulatory effect, anti-inflammatory effect. They reduce the oxidative stress. They allow for better mitochondrial function. And it is important to remember that these cells are found in the ovarian stroma and never inside the follicle. So that means they are acting through a paracrine effect, acting through their secretome, but they cannot really form the oocyte or the granulosa cells, and they are retained for a while within the ovarian stroma before they are destroyed. Now, the first baby which was born through autologous stem cells therapy was reported by Edisi in 2016. Now, you can see from 2016 we are now on to 2024, but we just have a handful of case reports of children born through this treatment, because it's not really all that simple, or there is a lot we have to learn about this. Now, the next seminal paper, which was a breakthrough kind of paper, was by Sonia Jerez from Spain. And what this group did was, this was an observational study on 17 POR women, where they mobilized the bone marrow mesenchymal stem cells by giving G-CSF treatment. And this was given for 5 days, consecutive days. And then they collected blood from the peripheral blood and separated the CD34 circulating cells from this. And then these were delivered in a very complicated method through the ovarian artery by intra-arterial catheterization and into the ovarian vessel and ovary. And interestingly, 81.3% of patients showed improvement in the oocyte ovarian reserve within 4 weeks. The AFC increased, the AMH levels increased, and 5 out of 15 patients achieved pregnancy. Now, these positive effects were associated with the presence of FGF2 and thrombospondin, which are the byproducts of the mesenchymal stem cell. And this, sort of was a pilot study proving that mesenchymal stem cells from the bone marrow can effectively rejuvenate the ovaries. Now, they went on further to publish again, saying that, supporting their earlier theory that you could use stem cells to promote follicular development. However, they did not modify embryo quality. They could not change the age of the egg, though by changing the environment, the perifollicular environment, they could get activation of the follicles, and you could get the woman to ovulate. So this means that these therapies do work. However, at the moment they are in experimental stage, and practitioners should not really embark on doing them right, left, and center without the approved research protocol. Now, what are the limitations of this therapy? One, there is no standardization. Once you have extracted these stem cells, you need to characterize and expand them, because you get such a small, minuscule number, and you don't know what is the dosage, in what quantity is it required to act, what are the methods you should use, and safety, most of all, microbiological safety, genetic stability, and oncogenic safety. Once you're putting in these stem cells, you're encouraging some tissue to grow. Will it overgrow? Will you be able to control the growth or limit the growth to exactly the limitations that you want? And what is the immune response of the host? So they're invasive, they're expensive, and their efficacy is still under review. Going then on to a much easier therapy, which is the platelet-rich plasma. It is basically a growth factor concentrate. The platelets contain within the alpha granules a lot of growth factors and cytokines. And when you concentrate the platelets, you will get a concentrate of growth factor. We know that platelets are associated with healing. When as soon as they get to the tissue, the alpha granules release the growth factors and encourage healing. And that is exactly what we are tapping into. We are concentrating the growth factors and trying to get the healing going in various tissues. And here we are talking about the ovary. Now, how do you prepare the platelet-rich plasma? 20 ml of blood is collected in a tube with 5 ml of ACDA solution. It's centrifuged for about 10 minutes at 200 G. The plasma layer and buffy coat is then transferred to another tube. The red blood cells remain at the bottom. It is again spun at 500 G for 10 minutes, and then the resulting pellet that you get of platelets is taken out. It's mixed with 2 to 4 ml of supernatant, and then you can use it either directly, you can freeze it, or you can activate and use it. Now, one of the issues with activation is that if you are activating the PRP prior to putting it back in, the short life of these growth factors is the half-life is very short. So you actually, in effect, cut down the effective time of the PRP once you have activated it outside. And that is why some people believe that, you should maybe put it in directly, because it then gets activated only when it gets in touch with the tissue, and therefore the time of action remains a bit longer. How do you deliver this? You have these, they have the simple cyst aspiration kind of needles. You preload this needle with the PRP because there's a lot of dead space there, and you insert it transvaginally into the ovary. You can see here, you can, put in a little, pull it out, give multiple punctures. And after you have finished your PRP, push in a little bit of plasma, because a lot of PRP will still be within the needle. So to clear the needle, you need to push in a little bit of plasma after that. Now, it has been seen that a lot of factors which are released by the platelets are the same factors which are involved in follicular growth and maturation, in activation, in growth, and in ovulation. And so this is the premise on which you work to hope that the PRP will activate your silent or dormant follicles. Now, the first case reports that came out on PRP were from Greece, and then you had other people jumping into the fray. So we had these initial, which were all case reports, all suggesting that women who were premenopausal or with severe POI, they could, or they had pregnancies after PRP was put in. And just to give it a little bit of a background, it really came from the use in skin and ortho. There was a lot of use of PRP in skin and ortho, and when the success was seen in these areas, then people brought it into reproductive medicine as well. So after that, there were a lot of studies which came up, all suggesting that the markers, ovarian reserve markers, AFC and AMH, were increased. There was improvement in steroid synthesis, so the perimenopausal women started having more regular periods and a better steroid secretion. There was improvement in IVF outcome, both in increase in numbers, increase in usable embryos, and increase in pregnancy rate. Now, this was one of the largest study by Caglo in 2022, which was on over 500 patients, where again he showed similar results with a pregnancy rate of almost 20.5% and a live birth rate of 12.9%. And very interestingly, about 4.7% of the patients conceived spontaneously, which we know that with the POR, IVF is such a challenge because IVF is all about egg numbers. So if you can get these women to conceive spontaneously by putting in PRP, then nothing quite like it. So what is the proposed mechanism of action? Again, these growth factors, they restore the ovarian microenvironment, they improve the perfusion, they clear the ROS, improve mitochondrial function, and reduce degeneration and atresia. And it is also, some papers have come up to suggest that because the ROS is cleared, there are good effects, nuclear effects, as well as euplasmic effect. The mitochondrial mitochondrial function is improved, and thereby the ploidy, embryo ploidy is improved, and women who had previously only aneuploid embryos actually came out and had euploid embryos after PRP treatment. It was also suggested by a certain author that maybe when you're putting this PRP, it induces the differentiation of potential ovarian stem cells into new young oocytes. So one, it activates the dormant follicles. Two, it induces the stem cells within the ovary to actually differentiate into young oocytes, and therefore they are euploid. However, there is a flaw in this kind of a hypothesis, because if you look at the follicular development timelines after we put in the PRP, it takes about 6 to 8 weeks. And that is actually the time which from the secondary follicle, secondary to, getting into the recruitment phase. And this is the time when the theca development is, there, and angiogenesis starts occurring into this into the follicle, and therefore better delivery of the growth factors, and the decline of the effect occurs in 3 months. So that the VSELs are activated is a little bit of a stretch. Now, in our own place, we looked at it, and again in Poseidon group 3 and 4 patients, we found an increase in AMH, AFC, increase in oocyte numbers retrieved, and usable embryos. And we had a very good spontaneous pregnancy rate of almost 57%, and and even in the overall pregnancy rate, I would say 43%, which would include spontaneous as well as the IVF pregnancies. And the younger patients, of course, did much better with a pregnancy rate of 63.1%. The miscarriage rate, however, remains high because the numbers are so low, and generally it is the older women. Now, this is the kind of look that you get, but even though you get this look, please remember that all these oocytes all these follicles don't have functional oocytes, even if the AMH increases, and the AMH tends to drop after 3 months, with the younger patients doing much better than the older ones. So there were some reports suggesting that, these are just incidental findings and incidental pregnancies. So we had this one multi-centered RCT, which again showed that PRP did not increase the number of oocytes retrieved, but the interesting thing was that oocyte retrieval took place in the cycle immediately following the treatment, and we know that we need roughly about 60 days or 6 to 7 weeks for the action to occur. Another double-blind randomized controlled trial, which did a parallel on, they said that it is the mechanical effect of pricking the ovary which actually works, and not the PRP. So they did a comparison, and again what they found was that the PRP group had more numbers retrieved. In the intention to treat, the pregnancies were more in the PRP group. However, overall the pregnancies were more or less same in the two groups, though again the flaw here is that they put the PRP in the first cycle of pickup, and pickup is the wrong time to put PRP, because there is not much tissue in which this is going to spread. The ovary is already enlarged with the follicles. So in my experience, what I have seen, that absolutely the wrong time to put it, and we don't put it at that time anymore. We put it in the follicular phase of a cycle, and then 6-7 weeks later we do the IVF. So again, lot of unanswered questions and worries. There is no standardization of the technique. We don't know what is the dose to give, and should we activate it, not activate it. Of course, please remember that that there are certain contraindications like thrombocytopenia, or if there is any ovarian pathology, please do not go and put PRP there, because you're putting in a bunch of growth factors, and that may not be very good. Ethics and legality is something that you should worry about. With stem cells, you need clearance from ICMR, and one should not really get on to this trend of putting right, left, and center using regenerative medicine until things are standardized, until we have experimental proof that it is safe, which is the most important thing for the patients. We should not fall in for hyperbolic claims and misinformation. Sorry if I've taken a little bit of extra time. Thank you very much.
Thank you, Nalini ma'am. It was such an awesome presentation. We have our other chairpersons who have joined in also. I can see Chaitanya over here, and Dr. Chaitanya. He is an infertility specialist from Pune, and he is also the chairperson for the endocrinology committee of FOGSI. So, Chaitanya, would you like to say about the this PRP stem cell talk by Nalini ma'am? Chaitanya, you are muted. You are muted, Chaitanya. Please unmute yourself. Thank you.
Am I audible now?
Yes, you are.
Host was not allowing me to unmute.
Okay.
Anyways, so thank you for inviting me as the chairperson for this talk. And Dr. Nalini Mahasan madam has given justice to the talk, and she has told both the the positives as well as the concerns and the limitations while you are doing this PRP or using stem cell therapy for the ovarian rejuvenation. But there is a lot of things to be done in this field, and I think there's a promising field which will give us more positive results in future. Though as of now, it seems to be more of a research technology than using it bedside.
There are many comments, Nalini ma'am, for you. Excellent presentation, nice presentation. And I right now do not see any questions, but if there are any questions, please just answer on the chat box.
I just wanted to ask Nalini madam, in your study when you were doing PRP, was there any AMH cutoff or was there a range in which you did these PRPs?
We actually started with, we took the Poseidon group 3 and 4, but we really start doing it below 1 nanogram, 1 and below 1, not 1.2 also. Okay. 1 and below 1 is what we took.
But then 0.5 to 1, was that the range? Or 0.7 to 1 or what?
No. We separately looked at those patients. That's what, I couldn't go through the whole presentation, but the ones with very low AMH, if in fact we've taken 0.09 to 0.5, and in that group, or if their tubes are open and you can get, we had a 50% pregnancy rate, and within the first 3 months we thought before, let's see if the eggs, if AFC increase, and in that time we just did timed intercourse and monitoring for them, or they said please do an IUI, and so many of them conceived. So the younger women with a lower count, with even a very low count, if they have no other factor, they do very well, because not only is it the ovulation, it is the secretome, the granulosa cell and the endocrine function which improves. I think that is also something that helps towards the pregnancies. That's my personal feeling.
Okay. And how many cycles of IVF you had to do to get 2 blastocysts?
No, it's not necessary that we waited to get 2 blastocysts. If in the first one we got a euploid, we managed. Some patients went on to have 3 cycles, some had 2, some had 3 cycles of PRP, but those were just 3 or 4 patients who had 3 cycles because they had very, very low AMH, so to try and bring it up. But if we couldn't get it up in 3 cycles, we just went ahead with the IVF to see, there's no point in going on and on with the invasive procedure if things are not working.
And every blastocyst was checked for euploidy.
No, if the blastocyst was not good enough, we went ahead with transfers without the biopsy. There were some, I think about 7 patients where we had totally aneuploid blastocysts. We could not go to transfer, but there were, patients who had no transfers earlier who went on to have euploids. So it depends, I think, on the age of the patient. And because that determines quality, and quality is everything. Though we did have pregnancy, a euploid embryo of that patient, I think, was very lucky with the 0.3 nanogram. We did 2 pooling cycles, and in the second cycle she got a euploid embryo, and with an endometrium of 3 millimeters, which we built up to 6 millimeters, she conceived and delivered. But those are the lucky few. Not everyone goes.
That's so true. Thank you so much. Thank you so much.
Thank you very much. So let us, that was a very nice interaction and very nice lecture. And I'm sure all the delegates will have a lot of take home messages from this talk of yours, Nalini ma'am. And now can you introduce the second speaker? Is Naina Patel ma'am here? One moment.
Yes, ma'am.
Yeah,
Yes.
okay. Yes, I can see you. So, yeah. So, chairpersons, one of you can introduce Dr. Naina Patel, please.
Meenu, there are few questions for Dr. Nalini. Dr. Nalini, if you
I'll reply them on the chat, not to worry. I'm
I'll
replying them on the chat.
in the chat box. So, is any Chaitanya, are you introducing Dr. Naina Patel?
Yes, I will do.
Yeah, please.
So let's move on to the next topic, and Dr. Patel is going to talk about surrogacy, the current status. She is the medical director of Akanksha Hospital and Research Institute located in the city of Anand in Gujarat, and she's also the medical director of Zivia IVF. She is considered as a pioneer in the field of IVF and surrogacy in India. She is the member of the Surrogate State Board, president of the Gujarat State OBGYN Society in 2010. She is the founder president of Gujarat chapter of ISAR. She was invited as at the Oprah Winfrey Show, the Heart Talk, TED Talks, Shastra Summit 2024. She has authored number of research papers, book chapters, and published and edited her own book, Advances in Assisted Reproductive Technologies. She's been the reviewer of JHRS, JRHM, JARG, Human Fertility, and T&F online. She has published and treated world's first case of thin endometrium by bone marrow derived cell therapy in CERM journal. She has published the first pilot study on autologous bone marrow derivative cell therapy for thin endometrium patients in Journal of Regenerative Medicine. And she has her interests are in regenerative medicine, reproductive genetics, and PCOS. So we all know Dr. Naina Patel, and let's hear from her about the status of surrogacy as of today. Welcome, ma'am, and over to you.
Thank you, Dr. Chaitanya, and thank you, Dr. Meenu, for giving me this opportunity and the ICOG. The topic for today is surrogacy. What is the current status? We know that it got legalized in 2002 with the ART guidelines. Till 2010, we were having it. And after that, 2012, medical visa was made mandatory for overseas patients. But then there was a prohibition on import of embryos from abroad, which still exists. We cannot import embryos from abroad for any reason. And finally, the Surrogacy Act 2021 was implemented in January 2022. This is on 22nd January 2020, before they were framing the law. The whole of Rajya Sabha, about 80 members with union ministers, and from Gandhinagar, about 50 people had come to our hospital to see what exactly, how surrogacy is being done. They interacted with the surrogate mothers, the intending couples, and they went up with what, like we were taking insurance, everything, and a lot of input they took from us and went there. So why this new act was needed, the Surrogacy Act, to regulate the practice and process of surrogacy, so that there won't be any incidental exploitation of any party concerned. And the main salient features were the expenses, what are the qualifications, what about storage of embryo gametes, application for obtaining a certificate, insurance coverage for the surrogate mother, number of attempts of surrogacy, form of consent from the surrogate mother, and number of oocytes to be extracted, embryo to be transferred. So there is regulation of the surrogacy clinics, regulation of the procedure, registration of the surrogacy clinic. There are National Assisted Reproductive Technology and Surrogacy Board, state as well as national. Then there is appropriate authority, and finally the offenses and the penalties. So we know that there is a national board where we have our representative too, but there are from government, bureaucrats, even social workers. And then we have the state surrogacy board, where we have so many people from health minister to the secretary, and which is functional in many states, but unfortunately not yet functional in some of the states. Most important is the role of the appropriate authority, who is at the district level. There is a state level appropriate authority also, but the district level authority is also there, like we have in the PCPNDT, who can grant, suspend, cancel surrogacy clinic registration, enforce the standards, investigate and take legal action if there is any breach, take legal action against unauthorized surrogacy, supervise the implementation, recommend any rule modifications needed. Then they can act on complaints against surrogacy clinics. And when you give the application, within 90 days, they'll come for inspection. And also they are the one who will grant the required certificate to the intending couple or a woman surrogate mother. First and foremost, any clinic who is wishing to do surrogacy, they need to apply for registration to the appropriate authority. It should be online as well as offline, and every application for surrogacy clinic registration should be accompanied by an application fee of ₹2 lakh. This is the form 3, which is the application form. You can go into the details and fill up accordingly. There is a set rule for minimum equipment required, minimum staff requirement for the surrogacy clinic, and then the minimum physical, like the reception area, consulting room, storage room, records, etc. with lab, the clean area, sterile area has been properly outlined, and you have to follow that to get the registration once they come for inspection. Once you give an application, the national board or the national registry or the state board or the appropriate authority, it is the appropriate authority of your district who will come to inspect the premises, equipment, records, and this could be without any prior notice. And once the inspection is done, you are also required to ensure there with them the safety of the stored gametes and embryos during the entry and research procedures. So they will not touch any of your stored material. After they are satisfied with all the criteria, they will issue a certificate of registration, that is Form 4, Certificate of Registration for Surrogacy Clinic. And this is our certificate which has to be displayed at a conspicuous place in your clinic where everybody can see that. Without registration of surrogacy clinic, no one can do surrogacy. Now, steps to obtain the issuance of certificate of essentiality. Any couple or a woman who comes for surrogacy, we can start the procedure of embryo transfer only if we have the certificate of essentiality. So the first stage, second stage, and third stage. In the first stage, you will need the certificate of medical indication. Second stage will be the certificate of eligibility for the intending couple and the surrogate mother. And the third stage will be the court order of parentage and custody. Now, who can opt for surrogacy? Any Indian origin couple or OCI, they should be married. The age of the female 23 to 50 and male 26 to 55. The intending couple should not have any surviving child biologically or through adoption or through surrogacy unless the child has a severe disability or a life-threatening condition. And that has to be confirmed by the district medical board. A single woman of Indian or overseas can do it, but she needs to be a widow or divorcee. If she is not ever married, she cannot do it. And here the age is again different from 35 to 45 years, and they should not have a child, same criteria as the couple. Overseas citizens are NRI, OCI holders or Indian origin citizens, person of Indian origin, but they should fulfill the prescribed eligibility criteria under Section 4 of the Surrogacy Regulation Act. And when the couple, husband and wife, both are overseas citizens of India, they have to go according to the guidelines of the Ministry of Home Affairs, and they need one extra certificate than an Indian couple with Indian passport or NRI with Indian passport is doing. We have to get that permission again from the national board. What are the medical indications? Absent uterus, MRKH, failed attempts to multiple IVF, and they want each and every IVF report why it has failed, multiple pregnancy loss, each and every, even they ask for product of conception, what it was, and then medical conditions like chronic kidney disease or heart disease. This is the application form for the intending couple, Form 10 and Form 10A, that is for a single woman, 10A. Now, when you are giving this, the manner of application should be that you should attest you should attach many documents, one of them being the proof of marriage certificate. If she is a widow or a divorcee, then the death certificate of the husband or the divorcee decree should be there. Proof of age, proof of that is birth certificate or 10th class certificate is also allowed. Then the intending couple also needs a medical indication from one of the doctors where they can say that, okay, she is a genuine case who needs surrogacy, or a strong document robust saying that she cannot carry and she definitely needs surrogacy. Now, once all these documents are given, the district medical board and the chief medical officer, like we have the chief gynecologist in the civil hospital in Anand, who will verify all this. If need be, he can also call that female to check whether it's really MRKH. We have put MRI reports also, or if she genuinely has a uterine problem and they are needed. So there is a district gynecologist, pediatrician who make this board, and they will give this medical indication certificate along with the appropriate authority. This is the list of documents that is required: Aadhaar card, passport size photos, then marriage certificate, death certificate, I said that before, and the relative of the intending couple. Supposing the couple dies, who will take care of the custody of the baby? So that intending couple will also, who agrees to take the custody of the baby, will have to show their Aadhaar card, passport and passport size photographs. Finally, if everything is fine, medical indication certificate is Form 12 that they will get it. And these are the list of documents needed, checklist for medical indication certificate also. So this additional document for overseas is letter from national board as preliminary okay to proceed, or letter of recommendation, whichever is given by national board. Now the eligibility certificate for intending woman or a couple is 17 and 17A. Checklist for eligibility certificate is again this. I've already mentioned, and this is a huge list. You can take a copy of this, but this is all the documents. Lot of affidavits. I'll tell you how many affidavits we need before we actually get this certificate. Now the surrogate mother, she should be a willing woman, not necessarily relative or a friend. She must be married in the age group of 25 to 35, have one child, husband's consent. If husband is not there, it's better to have relatives' consent. She will not donate eggs. She will do only once. For one couple, if she has failed for 3 embryo transfers, she cannot become surrogate again for anyone. And she must approach the appropriate authority that I am willingly doing it. Medical fitness is required, psychological fitness from psychologist or a psychiatrist. And it should be altruistic, in which no charges, expensive fees, remuneration or monetary incentives will be given. Only the medical expenses and other prescribed expenses incurred on surrogate mother and insurance for the surrogate are given to the surrogate mother or a dependent or a representative. So these are the list of documents. Here also you'll need Aadhaar card, age proof, self-attested birth certificate, marriage certificate. The birth certificate of the number of children she has also has to be attested and given. An affidavit from oath commissioner, then the medical gynecologist, physician certificate, psychologist certificate, and the other documents which I mentioned should be there. So these are the list of documents. And even in surrogate, the surrogate's husband or family members will give their Aadhaar card, PAN card, and passport size photograph. Finally, if all this is acceptable, the surrogate screening of surrogate mother Form 19 is applied and you will get that. The psychological fitness certificate is Form 14, which is signed by the registered medical practitioner who is either a psychiatrist or a psychologist. And these are the expenses that are allowed: travel, follow-up charges, well-being of the surrogate, expensing covering any possibility of maternal mortality, postpartum complications, and medically related procedure. Consent of surrogate mother is Form 2. You have to see that she is giving consent to all this. She understands in her own language. No need to type it in vernacular language, but it's always better. And this has to be properly counseled to her that what you are signing is getting all this thing written over here. Affidavit of intending couple's relative is this particular format only, where you give it with the photo. Insurance for surrogate mother now must acquire comprehensive insurance related to pregnancy, complications, postpartum, and 36 months after death. So 3 years insurance The premium is paid by the couple. And finally, then comes the parentage and the custody of the child. The judicial magistrate will call the surrogate husband or the single lady with the surrogate and the husband and the couple, and then she will question directly both of them. How do you know? When did you meet first? Why are you doing this? Is the medical indication certificate correct? Once all this is confirmed, then they will get this pre-birth affidavit, that is order of the parentage birth affidavit. Without this, you can never even start. And when all these documents are given, an essentiality certificate for intending couple is issued by the appropriate authority. And then only, this is the checklist for essentiality certificate, and this is the final document. Once you get this, then only you can start the procedure for embryo transfer, and for OCI is one extra letter from the National Board. Form 11 is the essentiality certificate. So nobody can promote or pursue surrogacy unless for specific cause. Before conducting, all the potential side effects and consequences must be explained to the surrogate mother. Obtained written informed consent must be given. And one more certificate, she can do it before the embryo is transferred in her, and there is a special form for that also, where she will write for the withdrawal. Number of embryo transfer is 1 blastocyst. In explainable circumstances, you can go up to 3 embryos. This is the withdrawal form consent from the surrogate mother who started, but now after the permission, she doesn't want to do it. Medical termination of pregnancy for medical conditions is the form 18. We have to inform the appropriate authority, but in case of emergency, you can just call or send a WhatsApp message, do the procedure, and then do this. And this is the certificate of birth. So list of documents for approval is so many. This is what you need for approval for surrogacy. Required affidavits. So affidavit from the couple for genuine medical records, confirmation that they don't have a biological child, one more affidavit, insurance affidavit. Again, if they are separate, the couple stating that arrangements for custody, if by chance they undergo divorce, who will take care of the baby? That also affidavit has to be given. If in death, who will take? Undertaking by the nominee, that also we have to do an affidavit. By the couple regarding the creation of embryos, whether they are using their own gamete or donor gametes, there is an affidavit. And by the surrogate mother and her relative, an affidavit. So these many affidavits you need. Maintaining the records, all the records, charts, reports, consent letter, agreements have to be preserved for 25 years. Only in case of criminal or any other proceeding, you may have to do it for more years also. And this can be available for inspection at any time without any notice to the appropriate authority or any person authorized by appropriate authority on their behalf. The offenses are huge. They are saying that if you found exploiting a surrogate mother, or you are advertising for commercial surrogacy, or you are sure there is a case of abandoning a child, or selling of human embryos or gamete, or importing the embryos, or conducting sex selection, the penalty can go up to imprisonment 10 years and 10 lakh rupees fine. And any person, it could be a medical practitioner, gynecologist, pediatrician, embryologist, or the person who is not a medical person but owns a surrogacy clinic, can have this penalty. And this is a cognizable, non-bailable, non-compoundable offense. Now, there are recent notifications coming. First of all, the insurance coverage, a lot of insurance companies have been informed that they should be giving the surrogacy insurance. For embryo transfer and gametes from one clinic to another clinic, there is a notification how we should do it. There is declaration form 16 to 24. It's quite simple. Online it should be done, and all these forms should be, the affidavit should be done, and then the embryo transportation can be done. So these are form 16, 17, 18, 19, 20, 21, 22, 23, 24. From the holding clinic, from the receiving clinic. So you can go through these forms and do it online. Again, on 11 July 2023, this is for ART clinic, who can be an embryologist. First, it was MCH embryology or urology, but now a general surgeon with experience can also do it. And finally, this was a big change which has come up, because surrogacy is done at the fag end of the reproductive career, where the eggs are exhausted and donor gametes were not allowed. But 21st January 2024, it has been allowed that one of the gametes can be donor in case of surrogacy. And then this is the latest, which got on 24th June, that a couple opting for surrogacy, there will be a maternity leave allowed for the intending mother. There were a lot of gray areas, lot of challenges, RTIs going on in the court, and one by one the amendments are coming up. But you can see that it's a difficult law, and a lot of people have issues with it, so they are going to the court. But to conclude, I'll say definitely the Surrogacy Act has established a legal framework which ensures adherence to ethical standards, protects the right of all involved parties, enhances transparency, which is very essential, and clear guidelines and procedures minimize misunderstandings and disputes. The restriction of age, a female of 44 and husband of 56, they can't do it. Couple with a child, because 2 children family is a norm. That is also MRKH, having 1 child but wants a second, cannot do it. Purely altruistic makes it really difficult, and I feel to some extent it's unethical and exploitative on the part of the surrogate mother, because she's doing this for 9 months. And there are definitely some of these points, and the most difficult point are the penalties. They are so harsh and so unrealistic, making it more and more difficult. To conclude, I would say that Surrogacy 2021 is there to stay. It is little bit more regulated than empowering, but all said and done, we have to abide by the rules. But there is a light at the end of the tunnel, because we are seeing positive amendments being made to make it more practical and possible. Thank you.
Thank you, Dr. Naina Patel. I have been to your center in Anand many times actually, and very nice, good work that you are doing, and it was an excellent talk. And I hand it over to the chairpersons, but we will not have any questions, only in the chat box. So you can please answer the questions in the chat box.
Sure.
Yes. Yes, Dr. Shweta, Dr. Chaitanya.
Excellent talk by Dr. Naina, ma'am. And she is a renowned queen of surrogacy since, like, when surrogacy started in India. I think so the best person to deliver this lecture. And it was crystal clear. Actually, every point is so clearly mentioned that I don't think so many questions will be there. Dr. Chaitanya can add on.
No, an excellent clarity which we all got. So we have been trying to get the things in place at our end since quite a few months or days, but still the clarity is not yet been there with the authorities as well. So we talks like this or should help or would help them, to understand what exactly we mean by what, and that would be helpful for the things to fall in place, and the things will move on quite smoothly there onwards.
We'll answer the questions on the chat box.
Yes. Thank you. Thank you very much. Yes. Can we introduce the next speaker? Yes, Dr. Shweta. Or Dr.
It is my proud pleasure to introduce Dr. Sunil Jindal, sir. We can say a father of andrology at India, because he revolutionized and made that change of MCH to MS surgery, and we all know him very well. He is consultant andrologist and director of Jindal Hospital, gold medal and best postgraduate MAMC Delhi, 35 awards from different organizations, collaboration with multiple institutes for research, national, international, offline, online master trainer, golden play button awarded YouTuber, and we have been following his YouTube videos, publication, presentation, chapters in books and papers published in peer-reviewed journals, over 200 national, international presentation. And we know he has special interest in fertility enhancing endolaparoscopic surgery, microscopic andrology surgery, sexual medicine, special interest in surgical, medical, and lab andrology. We welcome you, sir, for your talk. Unmute yourself, unmute.
Sunil sir,
Yeah. So first of all, thank you very much. Thank you, Dr. Meenu. Thank you, Dr. Shweta. Thank you, Dr. Chaitanya. Dr. Naina is here. Dr. Nalini Mahajan is here. Dr. Madhuri is here. And thank you, everybody, for inviting me. And somehow it's a very interesting topic which I have received. paternal aging and ART. Everybody talks about maternal aging and recurrent pregnancy loss, but somebody at last has thought about the man. So thank you very much for giving me this topic, though this topic is very complex. I'm trying to simplify it. And I will not say it's very dry, but it's very different. So I'm going to speak on this. And I'll start right away because I just have 15 minutes to talk. So I'll just begin it. Let me share my slides, please. Yes, so welcome to, just a minute.
Your slides are not, your presentation is not seen.
No, this is my presentation. I mean,
Oh,
this,
okay.
I'm on the slide. I'm
Oh,
on the
okay.
slide. I mean,
Okay.
I'm speaking from my studio, which is an online studio, so I'll present everything on this itself. So
Okay.
let me unmute myself. You can hear me? You can hear me?
Yes, we can hear you very well.
Great, great.
Thank you.
So paternal aging, I remember that Abraham Lincoln had said something very beautiful. You know, he had said that you do not live by the years of your life, but you live by the life in your years. So any man who wants, just a minute. So any man who wants his children at any age should have the right to have it. And more importantly, with his own sperm, but he should be aware of the fact that it is not easy. It is not easy, and it carries a few risks, which I'm going to talk to you about over here. So I'll start with the first slide, please.
Sure.
So paternal age and assisted reproduction, well, very important for all of us to understand. Next slide, please. Next slide. So, paternal aging with assisted reproduction is something which every man desires for, but needs to know exactly that there are a lot of risks which are there involved with it, starting from the genetic problems to the recurrent pregnancy failures. And what exactly are the risks which could be there are that sperm as a carrier of genetic material we need to understand. So when we refer to a sperm, it is a functional cell, but it basically is a carrier of genetic material. And this genetic material may be damaged, which is a DNA damage which happens because there is very little cytoplasm which is packed in the head of the sperm. DNA fragmentation needs to be considered as a parameter of sperm quality and whatever the number of the sperms may be. But if the functionality of these sperms is less, well, then we need to understand that the functionality is less, and the less functionality will lead to poor results. So the testes is something very important. It produces sperms in 60 to 70 days. But what we need to realize is that spermatogenesis is very complex. And hundreds of millions of sperms are made in every ejaculate, 24 into 7. There are spermatogonia which are present. These spermatogonia have cells which are nascent till the time of puberty. But at puberty, a primary spermatocyte is formed, which divides into two secondary spermatocytes. These secondary spermatocytes, further divide into spermatids, which are haploid cells. These then develop an acrosome and they develop a tail to form sperms. Now imagine this happening at such a large pace, millions of them being manufactured with very little cytoplasm, and all the DNA with a man who is aging, And these sperms then get released. Once they are released into the lumen of the seminiferous tubules, they get this beautiful chance to be a part of the ejaculate, and finally one sperm meets an egg. But the interesting thing is that the sperm nucleoprotein is very important and its maturation is very important. So in the spermatogonium, nucleoprotein is histone as the main constituent. As this matures, histone is converted into protamine 1 and 2. And for a mature sperm nucleoprotein, it should have 85% protamine and 15% histone. This is mature nucleoprotein. However, something interesting happens that whenever histone is more than 15%, it is known as immature nucleoprotein. And this nucleoprotein, which is immature, is also the DNA fragmentation, which normally happens. Paternal aging does exactly this, where these sperms are not able to develop maturity. Now, what are the biological mechanisms of sperm DNA fragmentation? Because these all are a part of the aging. First of all is if there is a protomination failure, where there is replacement of histone to protamine during spermiogenesis, oxidative stress, which can take place during the epididymis transit, post-ejaculation leukocytes, immature cells, abnormal cells, apoptosis during sperm maturation, and more importantly, it affects everything from natural conception. And in natural conception, you normally have arrests and low cleavage rates in the second cleavage state. Now, high sperm DNA fragmentation therefore is associated with an ability to achieve a normal pregnancy. So what happens in IUI? This is a beautiful, I made a slide out of this amazing paper where they studied and they compared live birth rates in intrauterine insemination in patients who had a normal DNA fragmentation to patients who had a high DNA fragmentation. And while the live birth rates of IUI in patients with normal fragmentation was 19%, but with a high fragmentation, it went down to 1.5%. Furthermore, when IVS was done, this is a beautiful meta-analysis of 16 studies, about 3,000 patients, where they did IVF and ICSI of patients with a high DNA fragmentation. Now, normally, with a normospermic, a semen analysis which is normal, and IVF and ICSI should have the same rate. But interestingly, over here, you had 26% IVF pregnancies and 42% ICSI pregnancies. Over here, ICSI had a reasonably better chance of giving a pregnancy in a high DNA fragmentation. Now, what's the clinical value of DNA fragmentation in IVF and ICSI? It affects fertilization, embryo development, pregnancy, miscarriage, and postnatal development. I've brought this slide over here because further on, when I'm going to talk about paternal aging, I'm going to just open up the research which is there available today. So, oocyte repair is very important. So, the younger the woman, the more repair it could happen. So, whenever I have patients for micro-TSE, which I have lots of them, the first thing I see and ask them is, what's the age of your wife? And the reason is that the younger the woman, the better the repair will be of any DNA fragmentation in these sperms. In fact, oocytes are able to repair at the pronuclei stage prior to syngamy. And they can repair single strand damages. They cannot repair double strand damages. And the age of the woman has a major part to play in this. So, management of DNA fragmentation, well, of course, we all know is lifestyle advice, use of antioxidants, recurrent ejaculation, treatment of underlying condition like a varicocelectomy, antibiotics, use of ICSI. Another method, if ICSI fails, a sperm selection after failed ICSI, or testicular sperm for failed ICSI. This is a beautiful paper, and this is a very, very amazing paper of Sandro, where he showed that the ejaculated sperm of the same man would have a 20, if 23% of people, 23.6% DNA fragmentation, and the clinical pregnancy rate in these people was 6%, compared to that when the same people were taken up for a TISA, the testicular sperm had only 4.8% DNA fragmentation, and the clinical pregnancy rate went up to about 44%. So, what is the reason that sperms with poor DNA are successful in ICSI? So, 30% of women having ICSI have no detectable problem. They are young, a good capacity to repair DNA damage, even if the sperm is of poor quality. And a significantly fewer good quality embryos are available to transfer in women more than 40 years of age, reflecting that age has a major part to play since the repair is less. In ICSI, the gametes are not subjected to prolonged culture so that the sperms have less damage. And in ICSI, basically the oocyte is also protected because it is not exposed for a longer time in the media. Now, let me come on to the changes with paternal age. So you have some histological alterations. Testicular vascularization goes down. There is thickness of the basal membrane. Sertoli cells decrease. Leydig cell decrease. Germ cells decrease. There are hormonal changes, we all know. Free testosterone is less. Total testosterone is less. Sex hormone binding globulin is less. Is more. FSH levels increase. LH levels increase. Inhibin B levels increase. In the basic semen parameters, when you age, semen volume goes down, semen motility goes down, morphology goes down, total sperm count goes down, sperm DNA fragmentation increases, and there is increased incidence of oxidative stress. Now, epigenetic modifications is very important because epigenetically it has been seen that the transmission of this damage does not only go into the next generation, but even in the generations next. And this specifically is a problem which happens in the DNA methylation, which I had spoken to you about. Now, what is the impact of age on fertilization rates? Decline in fertilization rates in men more than 40 years. ICSI, as I've shown you earlier, has significant impact. And the findings show that ICSI is good in these men to be used. So a practical point would be to consider ICSI for older men, which would give a better fertilization rate. Now, the second thing is, what is the biological mechanism affecting fertilization? So there are increased de novo mutations and DNA fragmentation. And there is also change in the DNA imprinting and chromosomal anomalies increase. You may need to implement some genetic screening to assess the sperm integrity in older males, but a DNA fragmentation, and in case there have been previous recurrent pregnancy failures, you could go ahead and do a further genetic testing of these men. Embryo quality declines after 50 years, blastocyst formation declines, there's higher aneuploidy if PGT is done. What can you do? You can use genetic chromosomal screening techniques to improve embryo selection. Now, epigenetic and genetic changes. There can be aberrations, and we all know that sperm genome decay comprises and compromises the embryo quality. So you need to consider at times a sperm donation or advanced genetic screening for older males if there are any genetic changes which you suspect in these men. Implantation rates, mixed results have been found. However, the implantation rates may be less. A practical point is to closely monitor the implantation success and consider some strategies which may improve implantation if this woman is older in age. Miscarriage rates are higher in men more than 50 years. Genetic abnormalities and DNA fragmentation is there, of course, in older men. Well, genetic counseling needs to be done, and PGT may be an option in these men. Perinatal risks, well, there is higher premature birth, lower birth rate, stillbirth with advanced paternal age. Ensure perinatal monitoring and counseling for couples with older fathers. See, there's another thing which happens. Most of these men also have women who are older. So if there's a young woman, then the chances of having a good baby, a healthy baby, is good, because even the pregnancy um, is not as high risk as it would be with increasing maternal age. So in the end, advanced paternal age affects various ART outcomes, fertilization rates, embryo quality, implantation, miscarriage rates. A very, very tailored approach is needed, which could be looking into DNA fragmentation, giving antioxidants, treating if there are any other issues present, giving a personalized counseling, going ahead for different genetic screenings, and essentially optimizing ART results in older men, because they really deserve to have a baby. Now, if there is deferred fatherhood, if there's a man who has deferred fatherhood, well, you can freeze his semen. It's simpler than egg freezing. Everybody talks about egg freezing. Please, somebody come over and talk about sperm freezing. And the importance of counseling on the risk of delayed parenthood are there. Oral antioxidants can be started. Sperm cryopreservation is important. And PGT is there to select the healthy embryos. Future investigation into DNA methylation, why it happens, what modification could be done, understanding the influence of non-coding RNAs on reproductive success. In the longitudinal studies, we really need to study these children and offsprings of men who are of an older age. We need to see the genetic, neurodevelopment, and psychiatric disorders if they are present. And of course, every man needs to assess his lifestyle, what he eats, what all things can prevent him to have a DNA fragmentation, and different strategies which I have spoken about need to be taken care of. Well, I'll conclude by saying there are a lot of challenges in this, strategies which I've spoken about, but in the end, every man, whatever the age, if he wants a child, deserves his child. And I'm sure following this, a lot of things would open up in the future for all of us. And thank you very much. Thank you very much for being here. Thank you very much for listening to me. I hope I have been in time. And even if I've shot up a few minutes, well, I'm sure you'll excuse me. If any questions are there, I'd be glad to answer. If I have to answer in the chat box, I will do it. And let me just stop my slide sharing. And thank you very much. Thank you very much. So,
thank you, sir, for a very elaborate talk. And sir, in your experience, have you observed, like for severe oligoacidoteratospermia, in your practice, do you prefer a testicular sperm over ejaculated sperm? Have you, practiced like that sometime?
see, I'll be very, very clear with you. If the person has undergone an ICSI earlier and he has failed, the patient has had a lot of ICSIs earlier. And see, most of these patients are such, they would normally come to you at an age which is beyond 30, 35, 40, because they already have tried a lot of things and they've already tried a lot of things going on. A lot of patients of primary testicular failure are such that they would be having a semen count which is better, say 10 years from now. It goes down to a stage where it comes up to cryptozoospermia. In these patients, a testicular sperm is always better in terms of doing an ICSI and very easily found too. But at times the patients don't agree to going ahead and getting a surgery. Women are very comfortable in getting a surgery done, but men are very sensitive about their testes because probably during childhood they've had some kind of trauma which may have happened and it stays with them. So, in case they allow a testicular sperm, it normally in cryptozoospermia is better, there is no doubt about it. But if they do not allow or if they're wary of it, then using a sperm from cryptozoospermia also gives pregnancies.
Thank you, sir.
Thank you very much, Sunil sir. It was an excellent talk. Awesome, very nice. And I love your studio and the way you have presented it as well. And there are some questions in the chat box. Please reply to the question in the chat box. And thank you, Chairperson, Dr.
Thank you,
Shweta.
ma'am. Thank you, ma'am.
Yes, thank you very
Thank
much.
you. Thank you.
Dr. Chaitanya and Dr. Manoj Chelani. So now we move on to our next session for today. Just give me a second. Yes, so recurrent implantation failure, what matters? So we have our chairpersons. We have Ramni Devi madam. Ramni madam, are you there? Okay, so Ramni madam is a managing director of Ramakrishna Medical Center and Janani Fertility Center. She's had many 10 gold medals in UG and PG. She's had IVF training, CS Dawn Prize, Indumati Zaveri Prize, and Women of the Year Award, Women Achiever Award, Dr. APJ Abdul Kalam Award. So many awards, many orations she has delivered, and she's edited many publications. She has been an investigator in Poise trial in Lancet, and again an SN Pandit and Shailaja Pandit Award, Best Women Doctor Award by Tamil Nadu State, and again many other awards that she has received. And Madam has been the Vice President of FOGSI, and also the International Advisory Board member of Fertility Society of Bangladesh. So thank you, madam. Thank you for being here. And Dr. Shobana ma'am, she is are you there, madam? Okay, the first in Karnataka to be accredited at the entry level standards by the NABH, first in North Karnataka to offer a fellowship course in reproductive medicine with RGUHS, first in many first to achieve a successful PGTA pregnancy. She is the recipient of the Indiewood Medical Excellence Award by Government of Telangana, a recipient of AHPI Award for 2 consecutive years. She is a visiting professor and PhD guide. She is also has a fellowship in perinatology and fellow of the Indian College of Obstetrics and Gynecology. Then our third chairperson, Dr. Sudha Prasad Madam. She is the director of Matritva Advanced IVF and Maternity Center at Gurugram. She has a more than 40 years of teaching experience, past president of IFS. She is also the past vice president of FOGSI, past president of AOGD, and she has had her fellowship from Boston, from Baylor University, Texas, and she's the one to start low cost budgeted IVF at a public sector institution in 2006. She has received many awards, state award by government of NCT, also fellowship to Hungary under Indo-Hungary 6. She has been the vice president of IFS and president-elect IFS. Again, she has been the president of IFS as well. So welcome, madam. And may I request the chairpersons to introduce our first speaker, Dr. Rishma Pai Dhillon, for her session.
I'm not sure if either three of them are there.
May I have the liberty and privilege to introduce our most beautiful Dr. Ishma Tilon Pai. She has been the past president FOGSI. She has received many awards. 2021 COVID Essential Heroes Award. I mean, she's actually a hero. And 2020 Glorious Legend FOGSI Award, a Business Leadership Summit Award, Inspiring Gynecologist of Western India by Times India Group, Midday Health Wellness Award as Icon of OBGYN Infertility, Women Empowerment Award by IMA, then HIV Research Award for Excellence in Medicine, Bharat Nirman Award for Women Entrepreneurship, recipient of 50 Outstanding Women in Healthcare Award, Middle East Leadership Award, Women's Achiever Award, Great Women Achievers Award, Nav Shakti Award, distinguished alumni and has organized many conferences. We have also had many orations, and we also had the privilege of having her giving an oration at POGS as well during my POGS presidentship. She has written many chapters and published many articles in leading journals and other publications. An outstanding DNB teacher, and one of the lady I can call beauty with brains. So, Dr. Rishma, please, the stage is yours to speak on the uterine factors in recurrent implantation failures. Thank you for accepting this talk.
Thank you, Mino. Thank you for inviting me. My pleasure always. ICOG, as you know, is very, very close to our heart, and any activities associated with that are our activities. So thank you. Thank you, Madhuri. You're always there, Shweta. Thank you. And if you just allow me a minute, I will share my screen. One second. Why is it going so slow? Okay, so now can I be seen and heard?
Yes, very well.
Wonderful, thank you. So I will just go straight into the talk. And so, as you know, today we are discussing a very, very complex problem. So let me start by saying that even the most complex problem is resolved in the end, because if there's a question, there's also an answer. And that is the answer all of us are looking for. How can we prevent or overcome recurrent implantation failure? And I'm going to focus on one aspect, and that is uterine factors in recurrent implantation failure. Because as they say, the womb may be more important than the home. This is the Barker hypothesis. And we all know that the uterus, the endometrial mucosa, they are the actual anatomical, functional prerequisites for continuing the species. And they're also an important limiting factor in the efficacy of human reproduction. So how can we overcome the issues that we encounter at the uterine level? Because we know that successful implantation requires a good embryo, good timed and arranged endometrial receptivity, and a good crosstalk between the two. And this receptivity window is a very small time frame, a window of implantation, which is orchestrated by an incompletely defined complex of endocrine, paracrine, and autocrine factors. And you can see the events that happen. The blastocyst comes there, there is hatching, the adhesion molecules are there, there is apposition with the endometrium, then there is adhesion, and then there is invasion of the blastocyst into the endometrial cavity. So what really is recurrent implantation failure, or RIF? Its definition has really changed over a period of time. It was called as the failure of clinical pregnancy after 4 good quality embryo transfers with at least 3 fresh or frozen IVF cycles in women under the age of 40, or more than 10 embryos transferred in fresh or frozen cycles. So at least 10 good embryos and the patient didn't become pregnant. It is called RIF. Then a little more recently in Fertility, Sterility, there was a publication that, age is the most important factor, and that new definition accounted for the euploidy rate on the basis of age, and that is what was considered. But now, like just last year, the European Society of Human Reproduction has come out with the RIF new definition, and it's a very generalized definition that RIF describes the scenario in which the transfer of embryos, which are considered to be viable, but has failed to result in a positive pregnancy test sufficiently often in a specific patient to warrant consideration of further investigations and/or investigation. So patients whom you think should become pregnant after a few tries don't become pregnant, that is RIF. The incidence is maybe around 10% of women who seek IVF. They just do not become pregnant. And however, there's a changing scenario, and recent studies have said that true recurrent implantation is rare. And if the patients have really good euploid, tested, normal, healthy embryos, less than 5% would fail to achieve a clinical pregnancy. basically putting much of the blame, if you will, or responsibility on the embryos. And so our question today is, what is the role of the uterine factor? If 95% is embryo, then what is the uterine factor? And is it really true that 95% is uterine factor? So very recently, 2023, the European Society of Human Reproduction, ESHRE, has come out with very good recommendations on recurrent implantation failure. So what have they recommended? What are the tests they have said? You do reassessment of lifestyle, reassess the endometrial thickness, and reassess antiphospholipid antibodies. That is the three things they want you to look at basically. You can, of course, and that's a question mark, can be recommended ultrasound, hysteroscopy, endometrial function tests, and endometritis tests. They do not recommend microbiome testing or uterine NK cell testing, which some centers continue to do. So very briefly, the investigations which are recommended as far as uterus is concerned, I'm not talking about other investigation, the other speakers will speak about it. 3D ultrasound, hysteroscopy, and none of the endometrial receptivity tests are actually, recommended. There's not enough data for that. You look for chronic endometritis if you're suspecting it. Endometrial thickness, you should definitely focus upon, and studying the uterine and vaginal microbiome is not recommended. I just mentioned that. As far as other factors go, and sticking to the uterus, uterine natural killer cell testing not recommended. T lymphocyte assessment in the uterus is not recommended. So, of course, the other tests like karyotyping or antiphospholipid antibodies, etc., thyroid function, all of those have to be tested as per individual cases. So we are going to focus more on uterine factors, starting with the starting with the uterine issues. So we know that the proportion of unidentified uterine abnormalities in patients with RIF goes between 14 to 51%. And many of these are undiagnosed till a good transvaginal sonography or hysteroscopy is done. So how should we really be assessing this? We are missing so many problems inside the uterus. So consensus even today is lacking. Which is the best method? Over the years, they said hysteroscopy is the gold standard. But today we believe that there are less invasive, good, accurate, and less expensive tests. For example, transvaginal sonography. Excellent test, particularly for diagnosis of polyps. However, for diagnosing uterine malformations, intrauterine adhesions, the sensitivity is low. The good thing is you can actually assess the outside of the uterus as well at neck cell structures, antral follicle count. So you get a more overall complete picture with a transvaginal ultrasound. However, most international studies are now saying that saline infusion sonography, SIS, is actually the best test. So it is accurate, it is inexpensive, non-invasive, so to say, gives you visualization of the uterus in 3 orthogonal planes. And you can pick up most of the problems with the saline infusion sonography. And you can see here how beautifully you can assess the first pictures of a normal uterus. Then you can see intrauterine adhesions. And the third picture is a nice deep septum, all picked up on 3-dimensional sonography, saline infusion sonography. Even submucous myomas, how deep they are, how much they're jutting into the cavity, all can be assessed by this. So, but obviously the other side still has its role to play. So hysteroscopy, because this study actually compared TVS and hysteroscopy and said that transvaginal sonography did not detect pathology in 120 cases out of about 800 cases. So office hysteroscopy has to be considered in a workup method prior to treatment, even if they have normal TVS, especially in patients with RIF. So those are difficult cases. And in these cases, hysteroscopy even today has a role to play. So coming to individual issues, polyps, have mechanical interference with sperm transportation, space-occupying lesions. Not only that, they also cause non-response to progesterone in that area. So implantation is not good. They also induce inflammatory changes. And because of all these reasons, you can actually see inflammatory markers like FOGSI 10 and 11 in the presence of polyps. All of them reduce the rate of implantation in the presence of the polyps. And of course, hysteroscopic polypectomy is the gold standard. Simple. You can do it in an office procedure. Mini hysteroscopy can be done. And with whatever technique you want, you can definitely go ahead and remove the polyps. And particularly, you see when polyps are like this, pretty large polyps inside the cavity, they will definitely interfere with the implantation. You can see these large polyps. So these kind of polyps definitely need to be removed and they'll improve success rate. What about myomas? All of us know that submucous myomas which are really sort of distorting the cavity, will have an impact and they should be removed. Subserosal fibroids, nobody's recommending their removal. So for many, many years, this is what most of us have studied, that they will cause contractions, abnormal vascularization, disordered cytokine profile, and that's why submucous myomas should be removed. However, there are studies now saying that even FIGO type 3 myomas, which are not indenting the cavity, and this large study of 1,000 patients and more very recently came out, said that even type 3 myomas are significantly associated with a lower implantation rate and live birth rates. And of course, if they're more in number and size, even if they're outside, they have an impact on pregnancies and live birth rates. So that is a big controversy which is ongoing. What about adhesions? All of us know the intrauterine adhesions definitely disturb the transport of sperms, avascular, non-responsive endometrium is created, and their thickness of the endometrium and receptivity is definitely impacted. And even after you do an adhesiolysis in a patient with bad adhesions, the results are not that great for implantation and live birth rate. And so conception rate after adhesiolysis is proportionate to the degree of adhesions that the patient had. Those who have minimal intrauterine adhesions, they get a very good pregnancy outcomes, whereas the severe ones, even after treatment, do not do that well. How about septum? I think it's one of the commonest things. All of us encounter it regularly on HSGs or on hysteroscopies. And a very recent systematic review, 2022, shows that it has a detrimental effect on live birth rates, pregnancy rates, abortions, and preterm births. So septum, over the years, we've been taught that it has a negative impact. And if you remove the septum, there will be a beneficial effect. However, studies, especially even the Cochrane review, which is the largest study that comes out reviewing many, many different papers, says that there is no evidence to support septum resection in this group of women. And so septum resection, again, is controversial. The biggest controversy really appears to be around endometriosis and adenomyosis. Classically, we have always considered that the patient has endometriosis, adenomyosis, her pregnancy outcomes are going to be poor, the egg quality will be bad, and the endometrium will be bad. And so we've always had this. But now you can actually distinguish the effects that these disorders affect on natural fertility. Their effect on natural fertility is different from that in the ART cycles when you're looking at the endometrial receptivity. So the impact is different. Classically, we believed that the adenomyosis, if it is there, implantation will be poorer. If there is endometriomas, the egg quality will be very poor. But recently, there has been evidence that, in fact, surgery, rather than improving the outcomes, actually is harming the ovarian reserve and worsening the outcomes of fertility treatments in patients with endometriosis. So all the recent evidence is saying that even the presence of endometriomas does not affect ART. If you have good the euploid blastocysts, even women with endometriosis will give you good embryos. Similarly, adenomyosis does not affect implantation. And however, you have to keep in mind that all these studies which are coming out now have been on HRT cycles for transfer. You're giving estrogen, you're giving progesterone to the patient, and then you're transferring these embryos. It's a possibility that you suppress the endometriosis, and that's why our outcomes are good. But a lot of controversy in this field. So to summarize this aspect, this particular aspect, anatomical aspect, European guidelines for recurrent pregnancy loss, not specifically for RIF, but it's very similar, say that there is no benefit of hysteroscopic septum resection, insufficient evidence supporting removal of submucous myomas, insufficient evidence to support removing fibroids that distort the cavity even, and removal of intrauterine adhesions also is not shown to be beneficial. So this is very, very radical guidelines by the ESHRE that almost all these things do not improve outcomes. What about genetics? I'm not going to go into the entire genetics. I'm just going to focus on the uterine factor as far as genetics goes. And there's a newly identified hereditary thrombophilia genetic factor, M2 haplotype of the annexin A5 gene. This works at the surface of the syncytial trophoblast. It has its anticoagulant function, which is necessary for the balance in the placenta and pregnancy. And so annexin A5 is indispensable for implantation. And it has been found that in these patients of RIF, there is high antibodies against this annexin 5 gene. And maternal as well as paternal M2 haplotype of the annexin 5 gene definitely is a risk factor for RIF. So I think we have to get deeper into the understanding of RIF, look at the genes at that site and see where it is getting impaired. Similarly, many studies are there which take biopsies of the endometrium at different phases of the window of implantation. And they can say there are 40 differently expressed genes which can classify the endometrium as per proliferative, pre-receptive, receptive, or post-receptive. So if you actually go deep into the endometrium analysis, you'll find that you can look for personalized medicine. In a particular patient, there could be a receptive phase which you are missing every time you're doing an embryo transfer. What about infection? There's a lot of talk now, a lot of focus on chronic endometritis. And this actually can be diagnosed by histological examination and then subjecting it to immunohistochemistry. Of course, even a hysteroscopy will give you an idea. You can see this edema or hyperemia and the presence of micropolyps. You can culture that material and see if you have strep or E. coli, etc. RT-PCR will give you that information. And we have commercially available tests. There is ALICE test, there is EMA test, as you can see, analysis of infectious chronic endometritis. And these tests will help you pick up endometritis. And if you treat that with implantation and you can cure that infection, the endometrium, the implantation rates are much higher, 37% versus 7%. So you can bring about that improvement. And many things are being done. You know, you can give antibiotics orally, vaginally. You can give pre and probiotics. Metronidazole, you all know, works very well. Vaginal microbiome transplants have been tried. So there's a lot of work going on, but there is no definitive evidence right now whether these things should be tried or not. Coming now to one aspect which is very, very specific. Can we actually see the receptivity of the endometrium by some specific tests? And can we do what we call a personalized embryo transfer? So endometrial receptivity, we know where there's a thickness is there, the pattern on ultrasound is there, the blood flow is there. That is the ultrasound picture. But can we on a biopsy pick up the exact window of implantation? And there were many tests available. There are tests available. There's the endometrial receptivity assay to give you the timing of implantation or transferring your embryos. There is the function test, the endometrial function test. And there is, of course, identifying inflammatory factors, particularly endometriosis, with the BCL6 marker for endometriosis. However, none of these tests have really stood the test of time. So very questionable whether these tests should actually be done. Endometrial thickness, we know, you can see many, many studies. This particular study, more than 10,000 cycles, definitely says that if the endometrium is between 8.7 to 14.5, your outcomes are going to be the best. And as the endometrium improves more than 8.7, you get even better rate. So endometrial thickness surely has a role to play. However, when you get a thin endometrium, it's very, very difficult to treat. All kinds of things have been tried. Sildenafil, aspirin, vitamin E, arginine, all things have been tried to try to improve the endometrial thickness. None of them seem to really work. And so it's always, you know, if you always keep on doing what you always did, you will always get what you always got. And so if we want newer, better results, we have to try new things. So many things have been tried. Some have worked, some have not. Endometrial scratching. Does it benefit? It is now recommended not to do endometrial scratching because it does not improve live birth rates. GnRH agonist and letrozole has been tried. Again, question mark, hasn't shown great benefit. There is maybe a benefit of growth hormone administration, not only for eggs, but also for endometrial receptivity. Autosiban giving before embryo transfer may have a role to play by reducing contraction. So certain things may have a beneficial role. Certain things are not known to benefit. Simple things have been tried. Intrauterine infusion of HCG to improve the chemokine response, angiogenesis improvement might help improve the outcomes. Granulocyte colony stimulating factor is being used last so many years, subcutaneous or intrauterine infusion. Again, some thickness may increase. There may be an improvement. Nobody really is sure whether it works. Even a combination of PRP intrauterine and GCSF subcutaneous has been tried, again, with mixed results. Good things are being said about the intrauterine administration of peripheral blood mononuclear cells. So when you actually transfer stem cells, again, some studies are saying that it could be beneficial. But what is really being recommended to us? The ESHRE has recommended really only one or two things. They have recommended review your estrogen treatment in thin endometrium. So make sure you're getting adequate estrogen for the endometrium to develop. If there is genetic counseling about pre-implantation genetic abnormality, lifestyle should be optimized, and you can recommend antibiotics for chronic endometritis. So out of all the interventions, these are the only things that they are recommending. They are not recommending right now PRP, HCG, scratching, GCSF. None of those things are being recommended. They've been tried in many different studies, but there's no serious proof. So eventually, when everything fails, we are going to have to resort in certain patients to surrogacy. In certain patients, you may need to even consider uterine transplantation, because we know it's a reality. Even laparoscopic uterine transplant has been done in absolutely dismal cases or with a completely damaged uterus. And of course, in the future, maybe we will have an artificial womb. We know that sheep have grown to full term outside of the womb in an artificial womb. And so humans may be next. And you can see that you can actually see in this image, there's actually a heartbeat. And these are real images when the sheep were grown outside the uterus. So let me end with this futuristic movie about growing babies outside of. Till that happens,
Introducing Ectolife, the world's first artificial womb facility, powered entirely by renewable energy. Ectolife allows infertile couple to conceive a baby and become the true biological parents of their own offspring. It's a perfect solution for women who had their uterus surgically removed.
So this is the future, maybe, but I want to end on a positive note, saying that we all know recurrent implantation failure is a very distressing problem, emotionally, huge financial stress to the couple, but there is still hope for these people. And so when you explain to them the long-term prognosis, and this was a very positive study, that 118 women who had RIF, cumulative incidence of live birth during the 5 years subsequently was 49%. So out of 100 women, 50% almost will go ahead and become pregnant if you observe them for 5 years or you continue to do some treatment for them. So there's overall a good prognosis. However, 51% will not achieve a live birth during the next 5 years. And that is the group of people that we need to focus on and try and find better and better solutions for this very frustrating problem of recurrent implantation failure. So no couple is infertile. I'm not there yet. Definitely we encounter problems, but definitely I'm closer than I was yesterday to achieving this dream that no couple is infertile. Thank you.
Thank you, Dr. Rishma. That was such a awesome, fantastic talk. Very, very dry, very disappointing topic, but you ended it in a very optimistic note. So very nice lecture. Thank you for that. And there are some
To try and
questions.
cover in a very short time.
Yes, yes. But you covered everything. That is, yeah, you covered every single thing. And there are some questions in the chat box. So can you reply to them in the chat box itself, please? Yes. Thank you very much. Thank you so much. Thank you. Can we have the next speaker?
Priya Kannan.
Yeah. Madhuri ma'am, will you introduce Dr. Priya, please? Yeah.
So our next talk is on embryo as the cause for the recurrent implantation failure. And we have none other than Dr. Priya Kannan to speak on it. She is the secretary of the Tamil Nadu chapter of IFS and also IMA Chennai. And she is also a Chennai district coordinator for IMA. She's a director and embryologist at the Rakshak Fertility Center, Chennai and Trichy. And she has several scientific contributions. And she's been the past president of ACE and organizing chairperson of the 8th International Conference of ACE that was held in Chennai. And she's also the executive member of the Indian Society for Assisted Reproduction. Over to you, Priya.
Thank you, ma'am. Thank you for the kind introduction, and thank you for inviting me to give the talk here on this very difficult and challenging situation that we always tend to face. Is my screen visible?
Yes, it is. Just
Thank
make
you.
full screen.
Yes, ma'am. So the topic given to me today is recurrent implantation failure. What is the embryonic contribution? As Rishma ma'am has already gone through this important one, which is the evolution of definition of RIF, I just wanted to take it here because it has got some important stuff in terms of embryos. One of the first attempts as it was done, as ma'am has already told, was about 20 years ago, when they said that it was about 12 embryos transferred in several procedures. Then they progressed that because then we started doing a lot of blastocyst transfers. It went from 12 embryos to more than 8 cells, or at least more than 5 blastocysts. The next definition added one more aspect of embryo to this definition, which was they had lesser number of embryos as we see, but then they added one word, which is good quality embryos of appropriate developmental stage. So as we see, there is a more addition in layers of embryos, the quality of the embryos that we are looking at here. And of course, the PGT consortium came out with the definition saying that more than 3 embryo transfers, which is the number of embryo transfers are also mentioned, of high quality embryos in less than 40 years, of transfer of more than 10 embryos in total, multiple ones. As ma'am has already mentioned, we got a very vague definition from Estre group right now. Finally, I think this is what we are looking at. Recurrent implantation failure is a very poorly defined clinical scenario marked by failure to achieve pregnancy after multiple embryo transfers. But as we have seen from the definitions, which is with the evolution, 1 is the number of embryos that is involved. 2 is the quality of the embryos. Number 3 is the number of attempts as the embryos were involved. And adding euploid embryos is something that is being contemplated on. So as we know, there are 2 situations here. 1, the embryo may never implantation failure can occur completely, which means we will not have the beta HCG as positive on the day 14 or 12 whenever you check. Another scenario is that it can migrate just into the luminal surface of the endometrium, may have traces of HCG detected, but will not proceed to have a clinical pregnancy at all. But as we have known, the factors that are causing this are the factors that we know and we attribute to are A, uterine, B, embryonic, and 3, immunology, of which I will be talking only on the embryological bit today. And every time a cycle fails, it may not happen because of the same factor in all the cycles. ART failures may not have the same etiology each time. Now, coming back to the embryo factors, there are 4 important factors that we attribute, which because of the embryo, we can have recurrent implantation failure. On topmost is embryo aneuploidy. 2 is the embryo quality. 3 are the incoming more advanced, like the research papers that is coming now on the molecular parameters, which is the epigenetics. And of course, inadequate culture conditions, which in turn will affect all 3 mentioned above: the aneuploidy, the quality, and the epigenetics. Taking the bull by the horn, let's just look at aneuploidy now, because that is the major cause of repeated implantation failures and it has been known ever since that at least half of the embryos we produce in the IVF lab are aneuploid. More so in the younger age group of women, and more so as the maternal age advances, the aneuploidy percentage in the embryos we create in the IVF lab increases. In a large study with about 24,000 embryos evaluated by the SART, there was a publication which said that the aneuploidy rate increased, like less than 35 years of age, when the maternal age was less than 35, was 46, whereas at more than 40 years, it became more than 66%. And the probability of having at least one euploid embryo decreased drastically from the younger ages to the higher ages. Then our own Gauram Majumdar and their clinic, they have published a data comparing implantation rates as per morphology when transferred as a euploid, cleavage, or a blastocyst stage embryo. When there is a good embryo in the cleavage stage, the percentage of implantation was about 43. And when there's a poor quality but euploid embryo, the implantation rate was 0%. Whereas in so it is not just the euploid status. We are forced to look at both the euploid status and the quality of the embryo. As we know here, and a large retrospective study, not all studies here are prospective, a large retrospective study, which included about 4,429 patients, which benefited from up to 3 consecutive single euploid frozen embryo transfers. In patients, you were able to obtain euploid blastocysts. Literally 95% of them were able to achieve a clinical pregnancy rate. This study was also mentioned by Reshma ma'am. It is titled very interestingly, Recurrent Implantation Failure, is it the egg or the chicken? And the authors have concluded clearly that it is the egg. So probably it is the egg and followed by the embryo, which they've concluded as the major reason for recurrent implantation failures. And they said they've also concluded that if we are able to have a good quality, a top quality euploid blastocyst, then the probability of a clinical pregnancy is quite high. And in terms, especially in the patients who had a history of recurrent implantation failure, it has been shown that there is an increased incidence of chromosomal abnormalities, such as translocations, mosaicism, and everything. And in support of that, we've also had many publications which have said that the chromosomal abnormality in the patients with RIF is slightly higher than the rest of the population of fertility patients. And hence, it is imperative that we do parental karyotyping in couples with RIF. And it is very common to see, or not very common, it is slightly, the probability of finding translocations and other chromosomal anomalies is slightly higher in couples with RIF than in couples with in other patients with infertility. We do know that if maternal age has got an effect on aneuploidy, that's probably because of the results of errors in chromosome segregation meiosis 1 and 2, resulting in higher aneuploidy rate both in the oocytes, which translates directly to the aneuploidy rates in the embryos. One of the largest studies which was done in 2011 with more than 20,000 oocytes obtained from 2,830 patients with the average of only 38 years. Their polar bodies were examined using the FISH method, detected about 20% aneuploidy in women at the age of 35, that increased to about 60% in women with over 43 years. And hence, probably this translates to aneuploidy in the embryos, which is one of the major causes of recurrent implantation failures. And another effect of maternal age, as we have seen, is zona hardening. And hence, there is the failure of the blastocyst to release from the zona pellucida. And hence, as we know that directly, what is the remedy for this is a laser-assisted hatching. But unfortunately, time and again, there has been studies which have been contemplating whether to do LAH on all patients with the advanced maternal age or not. But however, there is insufficient data to analyze the effect of assisted hatching on the number of important outcomes. But there has been various smaller studies which have contributed to say that LAH in RIF has contributed to slight improvement in pregnancy rates, but however, they did not translate to increase in live birth rate or decrease in spontaneous abortion rates but one thing was that the multiple pregnancy rates was increased in that study as well. The next important factor after embryo aneuploidy is the embryo quality. A good quality embryo is defined as the one having correct number of cells corresponding to the day of development, whereas the moment we have a RIF or a failure, we would want to go to more selection of the embryo, which is the way of having an extended culture and transferring only day 5 embryos, where the assessment is by 3 methods, where we assess both the inner cell mass, the blastocele, and the trophectoderm. Here I have put a picture of a very good quality 8 cell, morula, and a blastocyst. So the moment we know that there has been a failure in embryo transfer, the first cycle, it is imperative that we do an extended culture and transfer only blastocysts, where we know a top quality blastocyst has a lesser probability of having aneuploidy and hence a higher probability of having implantation and a pregnancy rate. So we know that the embryo quality in terms of euploidy status is important, but is only a euploidy status important? That has been shown that by Gaurav Majumdar and his authors, that it is not only the euploid status, but a good quality embryo by morphology is also important to give a better pregnancy rate. Along with that, there are other studies also which has come out with similar data. In a study which transferred 2,236 euploid transfers, the grading of the blastocyst, that is the inner cell mass, was one of the most reliable predictor of pregnancy outcomes. A grade A ICM had a live birth of about 55% compared to 32% of embryos with grade C ICM. Remember, all these embryos were again euploid. They were tested. PGT-8 was done. They were tested and found to be euploid. The results suggested that blastocyst morphological grading, particularly ICM, is predictive of ongoing pregnancy rates and live birth rates. When we compare morphology versus PGTA, we do know that the results of PGTA is extremely unconclusive. There are various conflicting studies on that. However, the large study, the multi-center study by Santiago Mune, and his publication has shown that there is a higher ongoing pregnancy rate per embryo transfer in couples who've undergone PGTA. However, but this did not actually give a higher live birth rate. Well, coming to the third factor, it is the epigenetics. We might be thinking there are only 2 things that we have known. This definitely is coming up. Outside of chromosomal euploidy, genetic mutation and alterations have an uncertain impact on the RIF. Epigenetic changes have been shown to impact implantation. As we know, DNA methylation changes are essential in early embryo development, and methylation alterations have found to create embryos from patients with long-standing fertility, although the relationship remains very casual. The next 4 slides are quite unimportant and not related to the subject as such, but I thought I'll just give an introduction on epigenetics. Epigenetics is nothing but modification of gene expression rather than alteration of the gene code itself. Just remember this: when the methyl group is present on a gene, it is turned off or silenced, and no protein is produced from the gene. There is a difference in epigenetics of sperms and oocytes in terms of when it is imprinted and when it is how much it is imprinted before that. In oocytes and before fertilization, the genome-wide methylation in sperms is about 90%, whereas in oocytes is only about 50%. just the same. And most of the methylation occurs occurs just before in the 36-hour window between the primordial follicle to the Graafian follicle, and in a pre-implantation windows prior to after fertilization, there is a complete loss of methylation, and the methylome is re-established beginning at the cleavage stage, going on until the implantation. And the pattern of methylation that is established in the oocyte has been proposed to determine the methylation patterns of the maternal genetic content in the embryo. And if the correct pattern is not established in the embryo, embryonic development could be potentially disrupted. A proportion of these imprinted genes, which are not reprogrammed after fertilization, remain in the germline methylation pattern throughout development, and it is reported that the methylome is sustained until the embryo is transferred into the uterus during the ART cycle. However, in bovine and murine embryos, it has been suggested that the contribution of IVF technique and the culture to the aberrances in the methylation patterns as well. So what is the association of this? We have known that there is an aberration. There could be difficulty in implantation, and maternal age also has a effect on methylation, especially when there is a failure of euploid embryo transfer. In 2018, Kawai et al. Performed a transcriptome analysis comparing the RNA in human blastocysts in younger women and older women, and they came to the conclusion that there was reduced expression of over 800 genes in women over 35 years of age. And hence, they concluded that advancing maternal age due to variations in gene expression caused by aberrant epigenetic mechanism may cause delay in embryonic development, resulting in poor implantation. What are the other possible factors that can affect methylation? Or our culture conditions in the IVF lab, and 2, duration of fertility. A prolonged disease state of infertility correlates with an altered methylome in euploid blastocysts, with particular emphasis on genomic imprinting regulation compared to assisted ART technologies alone. And hence, there has been proposals to say that probably if you're looking at more euploid embryos and better culture conditions, we could have better embryos to implant. And blastocyst is the way to go when we have RIF, and we need to have better embryo grading, embryo selection tools to go ahead with the selecting better embryos. Thank you so much for the patient listening, and I'll be happy to take any questions in the chat box.
Yes, Dr. Priya, I think that, you can answer the questions directly in the chat box.
Yes, ma'am. I will.
Yes, very much. So this was a very wonderful lecture.
Thank you. Yeah, thank you, Priya, for an excellent talk.
Thank you, ma'am.
I think it was self-explanatory, and I think it will really throw light in for many people on what really we need to look at in the lab also when we have patients with recurrent implantation failure. I mean, the next speakers, I think you're mute.
Yeah. Has Dr. Manish Pankar sir joined? Can I see him? One moment.
Ma'am, I am unable to see him.
Yes.
I think he is not there.
Okay, just let me call him up. In the meantime, just give me a second. Is Dr. Samidha around? Yeah, one moment.
Dr. Samida Dalvi is there.
Samidha, can you check? Yeah, one moment. I think in the meantime, we can take one or two questions. Madhuri ma'am?
Yeah, or we can just, he's joining, kya?
He's not picking up the phone.
No, so let us go with the panel, and then in case he joins, we can have his talk.
Sure. Let's do that. Nilesh, are you there?
Yeah, he's there.
Okay. So, let me introduce Nilesh Palkavade. He is from Pune. He is a fellow of Indian Association of Gynecological Endoscopists, clinical head and fertility specialist at Oasis Fertility. He is a chairperson of quiz committee FOGSI, second joint secretary AMOGS, treasurer of MSR, and he has had many awards. He is a gold medalist. He is a winner of Usha Krishnan Quiz West Zone Nagpur Award, Best Debutant POGS Dr. Smita Jog Award, and he's had many Shirish Daftari Award for the original research paper. He has also received V for Stree Award, ISAR Youth Icon Award, and AMOG Svurthi Award. He has had many publications, edited many books, and authored many chapters, and has been a faculty at various national, international, and state conferences. So, Nilesh, please introduce your panelist, and the stage is yours for the role of micronutrients in nutraceuticals in ART. Thank you.
Thank you, madam. Thank you so much. At the outset, I would like to thank Meenu Agarwal, madam, for arranging such a beautiful certificate course in infertility with the association of FOGSI and ICOG, and with all the stalwarts giving wonderful talks here. I won't waste much time, and we have a very limited time to cover all this topic about adjuvants in IVF. And this we are going to talk about not only about the adjuvants, medical adjuvants in IVF, but other adjuvants, whatever we can use in ART. So may I welcome all the panelists which are there. Dr. Priya Bhave. Then Dr. Priya Bhave is from Bhopal. She's a very good IVF specialist from the city of Bhopal. Do we have Dr. Priya? Dr.
No,
Mehul?
sir, we don't have any of the panelists here.
Okay.
I think the panel was later, na? Therefore, let's call the panelist, I think.
Okay, just give us 5 minutes and
Probably if there are any questions, we can just take them.
can take the questions in the meantime. Yes.
Hello.
Samita, yeah, Dr.
So all the questions which are related to the third party reproduction anyway will be discussed tomorrow in the ART laws. So one must remember that it's not, you cannot just use donor embryos just like that. And when you have to use a donor embryo, it's important that you don't use whatever you have stored embryos with yours. So if you want to go for donor embryo, you need to recruit a sperm donor, you need to recruit a egg donor. We have to make an affidavit, we have to register the affidavit, then create the embryos, and that embryo can be transferred. So you cannot just go straight just like that for a donor embryo. So it is, it's not.
There was a question, whether a single unmarried woman can go for surrogacy. So the answer is no. Only she has to be ever married, either a divorcee or a widow. Both are fine. They have to have a certificate, show the certificate of divorce or the widow. Single woman can go for IVF for her own self, but she cannot go for a surrogacy.
Yeah, so third party reproduction has now become quite difficult, and I think there were many unindicated things going on with third party reproduction, and therefore the government has come out with all these laws. So one has to be very careful when we advise any type of third party reproduction to any of the patients. Yeah, like yesterday I said that there's no entity as luteinized unruptured follicle. Basically, the follicle has ruptured, but then again it fills up with blood and it doesn't collapse, and therefore you think it's a unruptured follicle. It's unruptured. There's no use of giving trigger again, and should not be done. So if you closely monitor the patient correctly after 24 and 36 hours, where you find that you can find fluid in the pouch of Douglas, which indicates rupture. And if you increase the gain, you would also see that instead of sonolucent, it becomes hyperechoic, and that's because of the blood which is present inside.
And is Chaitanya there? Chaitanya Ganpule? Chaitanya, are you there? Dr. Shweta, are you there? Okay. So, Madhuri madam, you and I are there, and we will have a couple of more people, and Nilesh can start the panel with us.
What happened? Dr. Manish is not joining, no?
Dr. Manish just called and he said he's got stuck up in some emergency.
Okay.
He just called back.
There are, I think, one or two people, his panelists have joined, I think. Anyway, we are there, so that's not a problem.
You can start.
I think none of, Gunjan has asked, none of these things really increase the endometrial receptivity. So, all the adjuvants really are of no use. Yeah, we can. I think you can start, Nilesh, and we can. I think
Yes,
Dr. Chaitanya has joined, if I'm not mistaken.
Yes, I'll just call him.
Yeah, sure, madam.
Chaitanya has joined. He's also become the co-host, and I don't know about the others.
So thank you so much. At the outset, I would like to thank Meenu madam, Madhuri madam, convener, for joining as panelists. We have Dr. Samida Dalvi. Can I welcome Samida as a panelist too? And this is a practical discussion which we want to have today. It's a case-based discussions about adjuvants in IVF or adjuvants in ART. So don't limit your challenges, challenge your limits. Each day we must strive for constant and never-ending improvement. And improvement in IVF is, mostly by use of, different approach or different technique in this IVF. And that's why the role of adjuvants is so important. There are no secrets to success. It's the result of preparation, hard work, and learning from our failures. So it's said that if I had 6 hours to chop down a tree, I would spend the first 4 hours sharpening the axe. And friends, there lies the importance of adjuvant therapy in IVF. We can't jump onto treatments always, and it has to be methodical treatments, starting of treatment. So this is a first case, which is Mrs. Anuja, 36 years, with wife of Mr. Bhushan. They are married for around 8 years now, and she was a known case of PCOS with irregular cycles since menarche. But past 2 years, she's having 3 to 4 days cycle every 35 to 45 days. A PCO morphology and ultrasound, that is follicle number per ovary of more than 20, with no evidence of clinical or biochemical hyperandrogenemia. The body mass index is 28.7, and there's no other significant past medical or family history which is there. Now, the male partner, a 37-year-old businessman who is occasional alcoholic, there's no history of smoking, no other medical surgical illness. Semen analysis shows that the count is 10 million and progressive motility is grade 4, it is 20%, and grade 3, it is 30%, with morphology of 4%. He was given multiple courses of antibiotics and antioxidants, after which his semen analysis has not shown much of an improvement. Now, these are the parameters, that is the lab parameters of this patient. So we can see FSH is 4.2, LH is high 7.7, AMH is 7.4, and vitamin D levels are 22.4. With this background, we have also done a transvaginal scan of the patient, and we can see a PCO morphology. So now, since she is elderly and IUI probably is planned for her, I would like to ask here that what would be the approach for this patient? I can take this question to Meenu madam. Whether now her age is already 36. So elderly PCO, does it make a difference? And what is the role of adjuvants, especially in these patients? Whether we need to go for adjuvant therapy, improvement in the metabolic syndrome, if any, or use of antioxidants any before starting any form of treatment for such patient?
Yeah. As I'm looking at the history, she's married for 8 years. So whether they have been trying for the last 8 years or they have just started trying, if they have already tried for 8 years, her BMI is high. So she's on the obese side. And of course, we can see the counts are also not that good. So in my opinion, I would definitely add microceuticals, but I would probably not really go for IUI. Maybe an ICSI would be a better option for this couple. Madhuri ma'am, what is your opinion?
Yeah. I think IVF is a better option because it is said if the patient has been trying for more than 4 years, and if you look at the age, which is 36 years, and she has two factors. She has both male as well as female factor, and therefore, I think IVF would be a better option for her. But if she still wants to try an IUI, one or two IUI cycles, because if she's not taken any treatment in the past, I would prefer going for a gonadotropin low dose cycle rather than giving a combination of oral pills with gonadotropins, because again, that might not cause, because the FSH levels have to be more than the threshold value. And with PCOS with the AMH of 7.3 or something, a higher dose of gonadotropins FSH is going to be required. So I would, if at all she wants to go, I would prefer a gonadotropin IUI protocol rather than a CC or letrozole combined with gonadotropin.
Okay. So thank you, madam. I would like to just add a question to you, since the choice of drug is gonadotropin, of course, that will give us the better success rate. So how do you decide about dose of gonadotropin in the IUI cycle?
Yeah, so this patient basically, because her BMI is high, and she's got about 20 follicles, and I would start either with 50 or 70. And if normally if I have a patient who has a BMI less than 20, 24, I would start with 37.5 or 50. But if it's more than 25, I would prefer starting either with 50 or 75. And I will not go for a chronic low dose where we change our dose after 14 days, but I would go for a low dose protocol where after 7 days, if I find that there's no dominant follicle, which is 10 millimeters in diameter, I would then step up my dose by 37.5. So basically now we can use either a rec FSH or urinary FSH or HMG. It really does not make a difference. Now we have HMG, which is available in a multi-dose vial. So we have an option of increasing the dose by 37.5.
Right. Thank you. Thank you, madam. So clearly, if we are going for oral agents, they say that letrozole is better, but the consensus of the panel is that gonadotropins have an upper age. However, the starting dose should be, lower one, because we don't want a multifollicular development, of course, in a PCO patient, and a single follicle is better. So now, question to all my panelists: so which of the following adjuvants or agents can be used as an adjuvant for a better response in PCOS? These are your options. OC pills, dexamethasone, myoinositols, or all of the above are effective?
Basically, I would not use anything, any of these. But if I have found that her DHES is high, then probably I would give dexamethasone in the dose of 0.5 milligrams at 10 p.m. in the night for 10 days. That is from day 2 to 11 of the cycle. Only if DHES is high. Otherwise, I would not use OC pills. I would not use myoinositols or any other.
Meenu, madam, your take?
Yeah, I may use OC pills, but for a very short time, not like 3 months. It's just one cycle or less than that. Because, but I agree with here with Madhuri madam that myoinositol I may not use, but I may use metformin in a PCO patient, or a combination of metformin and myoinositol. Yes,
Yeah.
as well.
So this question
And
was
the
taken.
other thing is, now, if you look at the newer guidelines and if you look at the pre-treatment in patients with PCOS, what they say is either you give estrogens or progesterone, but you should not give it for more than 8 to 10 days. So therefore, they just they advise you give it from day 16 to 25. That is for 10 days. Either you can give norethistran, that's the best progesterone, because on day 2, if you do a progesterone level, the progesterone level is not high, because many a times when you give medroxyprogesterone, at times your day 2 progesterone level is high, and again that can affect the endometrial receptivity. So norethistran is the best drug which you can give from day 16 to 25. Or if you want to give estrogen, you can just give pure estrogen again from 16 to 25. And once you get the withdrawal, you can start the stimulation. But OCPs have been shown to decrease the pregnancy rate in women when it's used before stimulation, and therefore should not be used.
Yes. Madam, just highlight the dosage of estrogen and progesterone which we are using. Like for norethistran, what is the dose? And
I
for
use in the dose of 10 milligram twice a day, and I use estrogen in the dose of 4 milligrams per day in divided doses.
Okay, wonderful. So this question was taken from a standard book which said all of the above, but I agree with both of you that inositols individually don't have a role in PCOS, and OC pills, as Madhuri madam has clear cut say, the recent guidelines 23-24 have shown that the oocyte quality can be poor even in IVF patients, and the response can also be poor. So adjuvants and combination treatments, how do we manage resistant PCO cases? So these are the options which we have. Madam has already talked about glucocorticoids and her experience regarding usage of glucocorticoids. We can use only if you have clinical signs of hyperandrogenism or you have elevated
Basically,
DHEA.
if it is adrenal hypoandrogenism, then only your corticosteroids are going to act. And therefore, we look at DHES because we know that's the hormone which comes from the adrenals. Testosterone will be secreted by both adrenals as well as by the ovaries, and androstenedione basically more so by the ovaries, because it's the conversion of the cholesterol to androstenedione, then to progesterone, and then to the estradiol. So I think it's only adrenal and androgens, if they are high, and that is what we measure as DHES, then only dexamethasone works. Prednisolone basically should not be given.
Can I take this question to Samida if she's there? What are the indications of using metformin in the case of PCO? Is it for all? Is it for selected patients?
So I would like to give metformin only in the selective patients. Like, let's say if they are on higher side of BMI, they have irregular cycles, they have signs of acanthosis nigricans, or anything that tells me that yes, the patient does have some symptoms of hyperglycemia. So that is usually my take on metformin with irregular cycles.
So today the consensus has changed basically. And initially it was said that when you are giving metformin, basically it should be given for almost 3 months to see its effect. But then in 2014, the Cochrane review said that it can be used to prevent OHSS, where you're doing the downregulation with GnRH agonist. And then in 2017, they had another consensus where they said that if you've had a failure or resistance to your oral ovulagens and you're going to use gonadotropins, you can use metformin along with the gonadotropins, because it has shown to increase the live birth rate. And probably it could, many a times it's just not only the insulin resistance, but even if you have dyslipidemia also, I think metformin should be used, because we do not use any statins if a patient wants to conceive, because they're contraindicated if the patient wants to conceive. So if the patient especially has central obesity and has dyslipidemia also, you can use metformin, apart from having impaired glucose tolerance or type 2 diabetes.
Right. Thank you
Metformin
so much,
also
ma'am, for this.
helps in by default in reducing a little bit of weight if when they're trying to lose weight. So
Madam, one question to you, Minu madam, is that
Sure.
do you add inositols to metformin, or you use only metformin? What is your standard dosage of metformin? Because sometimes the patient can have gastric intolerance because of metformin. So what is the case? What are your options in that case?
Yeah. So if you give metformin 500 milligram even 3 times a day, that is 1.5 grams per day, and have it with meals. So rather than before meals or after meals, with meals, they say the I mean, they do better. I normally use a combination of metformin with inositol, but I think it depends on what protocols or what studies you are following. So I use metformin with inositol.
I don't use inositols at all in my practice.
Right, right. You said that yesterday, madam.
Yeah. Samida, your take on inositols, do you use it individually or as an add-on to metformin?
As an add-on to metformin, sir. I don't use it individually.
Yeah. So the message is clear that metformin is a tested drug and it has shown to be really effective as an adjuvant, especially in PCOS patients who have glucose intolerance, hyperlipidemia, and it will also prevent OHSS. And therefore, these are the patients in whom you are going to central obesity, where you are going to start metformin. Inositols in the recent guidelines, they have said that they don't have individually they don't have any role whatsoever. As an adjuvant to metformin, it may be used.
No, but again, they say that it still should be used in research setting. They have not said that it really is effective, because basically it is inositols are found in whatever we eat also. So basically, I mean, it can just be I mean, you can just increase whatever the dose of inositols by eating those ingredients which have inositols, rather, because inositol is a very, very expensive drug. So one should also think that you are adding more cost to the treatment. So a patient of infertility is already, is already so stressed out because of infertility, and then we are adding more cost to it. The patient gets more stressed out. So I think one must not only consider only just to give it as a placebo, but I think one should also consider the efficacy as well as the cost to the patient.
We agree with you, madam, that of course it adds to the cost, and therefore your rational decision making has to be made regarding inositols, and the take home is clear. Molecule which is now being tried with PCOS and many combinations are there is melatonin. So it has been said that it reduces the oxidative stress also. So each one of you, can you tell about metformin, or anyone? Minu madam can start.
Actually, I have had these company people who have come and told me, show me the studies of melatonin. It looks like a good option, but I have not yet used in my practice, to be very honest. Yes.
Yeah, I don't use any I don't use any adjuvants in my practice. And basically, if at all I do use CoQ, because I know that CoQ has shown to improve the mitochondrial dysfunction which is there, and we know that PCOS women, the oocytes, do have a mitochondrial dysfunction because they have more of cytoplasmic immaturity in their cells as compared to the nuclear maturity. So all these drugs, if you look, and even if you look at the ASHRAE guidelines as well as the PCOS guidelines, they say that none of these adjuvants really have a role in PCOS. If at all, you could use CoQ, but again, there are various studies, both in PCOS as well as poor responders. Some studies have shown CoQ to be effective, whereas others have not shown to be effective. And it's basically more so for mitochondrial dysfunction. Oxidative stress also, it corrects, we know, along with the mitochondrial dysfunction. But all the other drugs really do not have much evidence.
Madhuri madam, one question to you. Like we have stimulated so many patients of PCO, and we see that around 30 to 40% of patients may have poor oocyte quality, and we don't get that much blast conversion. Sometimes there are zero blasts which are formed. So, what is your take in such patients? In such patients, is adjuvant therapy going to be useful? Is we all know that lifestyle modification is going to be useful, but along with that, is adjuvant therapy going to be useful? How much time do you wait for second stimulation? What is your take on this?
Yeah, so basically, as I said, I would use CoQ if at all, but in only in about 20 to 30% it's going to help. But once you've started, you have to wait at least for a period of 3 months and then basically go for your next stimulation according to. There are many people who also do PRP and all those things, but I have no experience in that, and so I would not like to opine on that.
Minu madam, your take about poor oocyte quality at ovum pickup and in PCOS patient especially, and therefore no blast formed or poor quality blastocyst. What is your try in these patients? What do you try?
So I would
Nilesh, sir, just to interrupt you,
yeah.
Shweta Jha ma'am has also joined as a panelist. So ma'am is already there. Shweta called.
Good evening, Dr. Shweta. I'll come to you. Minu madam was answering. So Minu madam, yes.
So I would look at the age of the patient. If they're older age patient with bad oocyte quality, so you give them whatever they do not respond very well, to be very honest, in my practice, what I have in my experience. However, if they're younger group of patients with bad quality oocytes, we need to look at any history of smoking, their lifestyle, and maybe those are the patients I would give them CoQ, because that will give them a better mitochondria, and and wait for a couple of months and then change the protocol. Suppose I have used an antagonist protocol, I might change it to an agonist protocol and try for them. But if they're PCO and I do not want a hyperstimulation, then I will again go for an antagonist protocol for them. So depending on how much is the
Basically,
AMS, how much
these
is the AFC count. Sorry,
these
madam.
oocytes basically have, you see them now, they have a lot of granular oocytes, they have large this thing, plus they have a lot of perivitelline granules. And if you look at the this thing, they're quite dark oocytes as compared to normal oocytes. And usually whatever you do, basically they don't improve.
Right. And also rule out endometriosis, because many times I have seen patients who have endometriosis, their oocytes are also very dark, and they are not very healthy oocytes that we get from them.
So my one question is, what is we are talking about IVF, but basic question about other adjuvant therapy. We are not just talking about adjuvant. So is laparoscopy as an adjuvant therapy in PCOS still recommended, or you go against it? Meenu madam,
Nilesh sir, just to interrupt
no.
you, Shweta Kolja ma'am has also joined as a panelist. So
Yeah, I'm coming. I'm coming to her. I'm coming to her. I have noticed madam has joined. I
Yeah.
welcomed her. So I'll come from Meenu madam. I'll start and come to Shweta madam.
Okay.
Regarding your
I have
choice of
not
therapy.
done a drilling for I think last 6 years, not even a single patient.
Same here.
Shweta madam.
There are some indications, but at least I have not done for the last
Dr.
6
Shweta.
LOD, basically, when it is a lean, thin PCOS, then only we go for laparoscopic organ drilling. Lean, thin PCO, that is the indication. And though in definition of PCOS, there is no criteria to, get the FSH LH ratio or something. That thing has gone out. But for LOD, we say with high LH, in those patients also we go for LOD. So these two patients are, and resistant, clomiphene resistant patients, if they are, if there is no male factor, and if I'm planning, IUI or, I mean, something related to natural conception, and I'm also suspecting some tubal factors, then I can, club this. So these are few things where I would go. So raised LH, you've written, and young woman non-compliance. Okay. Fine.
So
I think so. I
basically,
am right on this.
yeah. So if we see the 2018 and 2021 guidelines of international consensus guidelines on PCOS, they don't rule out the treatment of laparoscopic ovarian drilling. It's the second line of therapy along with as an option to gonadotropin with IUI. If the patient doesn't want a strict monitoring with gonadotrophins and doesn't want to go for a gonadotropin IUI cycle and wants to try on their own, probably these are the young category of patients where LOD is still an option according to the international consensus 2021.
Basically, we'd have to weigh this thing. Gonadotrophins is a preferable option as compared to laparoscopic ovarian drilling. But if the patient doesn't want to spend or cannot come for monitoring, then probably laparoscopic ovarian drilling is done. But also, if you look at the evidence, there are several people, even after laparoscopic ovarian drilling, they really do not ovulate. And therefore, along with that, you also require, again, ovulation induction, probably with some oral agents. And if you compare the pregnancy rates, the time to pregnancy is much less when you're using gonadotrophins laparoscopic ovarian drilling.
Yeah, completely agree, madam. So this is just a picture to show that this is the way we don't have to do laparoscopic ovarian drilling. It's only the rule of 4 which we have, 2 to 4 seconds, 4 punctures and 40 watts. We all know that the success rates of the protocols are as such, and already Madhuri madam has talked about use of gonadotrophins only protocol, which is going to give you better success rates than combining them with other agents. So luteinized unruptured follicles, some patients give, some people give empirical cabergoline in few patients, some people give GCSF. Do you find these are useful for preventing LUF?
So basically, I said yesterday also that nowadays they say there's no entity like LUF. So basically the follicle has ruptured, but only thing it is not collapsed. And if you increase the gain and if you see properly, I mean, you can see hyperechogenic and basically it's a corpus luteum. So I don't think one should even consider LUF because initially it was said that LUF occurs when you have an inadequate LH surge. So people used to give a higher dose of HCG. There's no use of giving, there's no use of giving a trigger again if they feel the follicle has not ruptured. And I think in an IUI cycle, there's no use of a dual trigger.
Okay.
According to me.
So we'll just go to the conclusion of this case that, time is a very important factor once we consider elderly PCO patient. Even if their ovarian reserve is good, we all know that the oocyte quality is going to drop down, and therefore the time is always ticking in such category of patients, even if they are elderly patients. We are not going into the details of role of vitamin D. Obviously, there is some role of vitamin D in PCOS patient. And yeah, anybody about use of IVM as an adjuvant strategy or growth hormone in PCO patients? Anybody would like to speak about this?
IVM is said to be a good option, but you should really be very efficient and in doing the procedure. Everybody cannot do IVM, and your training and your how you deal with IVM is very, very important. And therefore, it's not really gained that much of popularity. Plus, if you look at the pregnancy rates, they are significantly lower than when you aspirate a mature oocyte. So I think in there is a clinic in Vietnam which does more than 300 or 600 cases per month of IVM. So probably they're experienced and therefore they do it. But I think in India, there are hardly a handful of centers who really do IVM. And I think one has to be trained. And there's no role of growth hormone in PCOS.
Okay.
IV
Shweta, you wanted to say something?
Yeah. In vitro
IVM is in vitro maturation of the oocyte, wherein you don't stimulate the ovaries and you aspirate the follicles when they are about 12 to 13 millimeters in size. So these are all immature oocytes, and then you mature them in vitro. And once they become mature, then you can do ICSI and you can use those embryos.
I think IVM, if I have to do, I'll probably do for a patient. I mean, recently, today only I saw a patient, ORADS 5, a young patient, 33, married only for 1 year. So there she does not want to wait for 2 weeks to get stimulated and freeze the embryos. So these are the patients, maybe IVM and of course PCO patients, but I don't have any personal experience in
Basically, if there is no ovarian involvement, I mean ovarian cancer, then ovarian tissue cryopreservation is the best option
Yeah,
for
but this is
when
an
you
ovarian
don't have
cancer,
time.
madam. This patient is ovarian cancer.
So then
Matlab,
you cannot even do IVM because if you're going to
it's
puncture
one side, it is unilateral. It is overrides 5. So we still have to do a laparotomy, staging laparotomy, see whether
Yeah,
frozen.
so
whether
when you do a staging laparotomy, you need to, whatever the normal ovary is there, you can do a cortical tissue biopsy. You freeze I mean, when you're dissecting this thing, whatever fluid is there, fluid is there in the, I mean, the culture media is there where you're dissecting, that can be looked for immature oocytes, and those can be subjected to IVM, but then you should do a ovarian cortical tissue cryopreservation at the time of surgery, because you would also know whether there is involvement of the other ovary or not.
Yeah, because
Very correct. So yeah, the summary is that elderly PCO needs treatment with caution. Protocol should be individualized. We should always use adjuvants which can help us to have OHSS free clinic. And yes, my metformin and few adjuvants like ultra coenzyme Q10 will have some role in improving the oocyte parameters in PCO patient. So we are going to the next case quickly. And this is, I'm not going into the details, but this is a case of male factor infertility where the husband has showed a semen analysis of 5 million count with 20% progressive motility and 3% normal morphology. The female factors, there are no major problems with that. AMH is 2.8, AFC is 14, and IUI was done 3 times and no positive result was obtained. ICSI was planned, antagonist protocol was used, and only one oocyte was fertilized, which could give a grade 4 BB blastocyst. So the patient has come to you now for further treatment after having undergone all these things and years of infertility. She has come to you. So in assessing a man in such cases, what is your strategy? What all investigations you would do? Any genetic testing? I would like to take this question to Dr. Shweta.
Hello. Why are we suspecting a genetic etiology in this?
He's a case of severe
Severe
OATS,
oats.
severe oligosteatoteratosphermia. Any role, I am asking, any role of any other testing, including genetic testing?
With this is his report or your normal?
This is not his
It's
report.
the normal
Okay,
range.
okay. What is the semen concentration for this patient? I'm unable to see the
5
5
million,
million.
20%.
Okay. I don't suspect it. I like to take the opinion of Madhuri madam for genetic evaluation of this patient.
See,
With one.
Yeah, so what is the, because when there were 10 M2 oocytes and only one has fertilized, there could be a male factor. So basically, I mean, you can do a Y deletion to know what it is, but because it's not an azoospermia, it's not really going to be effective. But it will tell us whether the male progeny is going to have any problem or not. But one has to look at the other chromosomal abnormalities, wherein you need to look at whether there are any deletions or there is any this thing, because it has been seen that if you have any other structural chromosomal abnormalities rather, you can have this problem, because I've had at least 3 patients who had structural chromosomal abnormalities, and they had low fertilization rate, and they also had a higher incidence of miscarriage. There are certain centers which are also doing tests for aneuploidy of the sperms. Actually, I did it in a few patients, but I didn't find it to be effective, and therefore I really don't do these tests. But probably doing a genetic analysis would be helpful. And we also need to look at if there's any other female factor, because having just the male factor is not going to result in failed fertilization of so many oocytes. And so probably we also need to look at if there's any other female factor which is present.
Also look at who's the embryologist who's done the ICSI, Secondly, all oats patient, I think it's good to subject them to just a karyotyping. It's not that expensive. So Klinefelter, any micro deletions are picked up. So these are the two tests which normally they pick up. And of course, male factor, whenever we find, it is good to put them on on antioxidants, because you're talking about microceuticals here. So whenever there is a male factor infertility, we give them the complete cocktail of all the microceuticals as well, along with the karyotyping. I think karyotyping is a good, should be done for male factor oats, severe oats.
Should not be a normal karyotyping. It should be the one which
Y
yeah,
chromosome.
Chromosome deletion and
and
client.
it also looks at the
Anything
structure as well.
less than 5 million, I think Y chromosome microdeletion with karyotyping should be done.
You can have three types: AZF, A, B, and C. So
And
those.
C. Yeah.
Though it
Madhuri
is
madam, you
more
were talking
effective.
about which type of karyotyping?
No. So you have this a molecular. I mean, normally what otherwise they do just karyotyping, just looking at the number of chromosomes. That's of no this thing. The I forgot the name now, but you should do wherein you get the
Microarray?
structure. Yeah,
Microarray.
microarray where you will get the structural abnormalities.
Yeah.
So just doing a normal karyotyping is of no use because it really does not help.
Yeah. Are you going to test for ROS in such category of patients where you are suspecting problem? Are you going to do a sperm DNA fragmentation index? Or are you going to look at other parameters, for failure or not improving sperm quality, like,
So
doing
I
a
think
ultrasound and talking?
basically ROS is not standardized, so we should not do ROS. Second thing is, in this patient, I don't think a DNA fragmentation is going to help because we're anyway going to do ICSI, because we normally do a DNA fragmentation to decide what further treatment has to be given, unless you want to decide whether you want to use the testicular sperms as against the ejaculate sperms if you have a very high DNA fragmentation. But then again, when you're using testicular sperms, the fertilization rate is much less than the ejaculate. So we have to weigh both whether we should use the testicular or the ejaculate sperms.
Dr.
And,
Shweta,
I
your
think
choice.
assessment of varicocele and all clinically anyway, it has been done. And only if it is grade 3 and it's a clinically palpable varicocele wherein the patient has symptoms, only those patients should be who should be operated. And if you look, there is really no treatment for teratozoospermia, but I always like to do a TZI index because that gives me a better, a better treatment option, what I should use for the patient. Wherein if it is really very high, then I would really prefer using a testicular sperm if the TZI is very high.
Yeah.
But my
So I would like to
embryologist
ask,
always tells me that if there is a growth arrest on day 3, then it is more of a sperm issue. But if there is no fertilization, then it could be both
It is
egg
an
and.
egg problem itself.
Yes,
So
yes.
basically, non-fertilization is more of a oocyte issue. That's what I said in the beginning itself, that you have to rule out a female issue because it's fertilization failure.
Right.
I would like to ask Dr. Shweta and Dr. Samida here. This patient is a case of long-standing infertility with a husband factor. So if you're planning a IVF again for this patient with this previous history of only one blastocyst formed, what is your approach while planning IVF? Are you going to plan IVF immediately in the next 2 cycles, or you are going to give antioxidants? What else you are going to do? We talked about the investigations. Now about the management, what are you going to do?
So given a chance, I would like to put the patient on some antioxidants for, let's say, 6 to 8 weeks further. I'll also counsel them about donor sperms in backup. And yes, I would also like to counsel them about testicular sperm as well, because he has just formed one blast out of 14 oocytes. And if I assume that the female parameter has been absolutely normal, then testicular sperms can be tried.
Okay.
But
So,
fertilization, they use
We
those
do not have that
chemical.
history. Yeah.
No, they have tried using chemical activation of the oocyte because many a times it's the failure of the oocyte activation which results in failed fertilization.
Yeah.
So
So they have
basically,
used
chemical.
calcium ionophores for IVA. in vitro activation of oocytes. That's what, madam, you're talking about, no?
Yes, yes. So
Regarding
I
your choice,
think day fertilization is related more to the egg rather than to the sperm. But here, because there is a sperm actor, I mean, you have to also do a electro microscopic examination is important in these cases, because many a times if there's defect in the acrosome of the head, then also you would have failed fertilization. So many a times an electro microscopic examination of the sperms may be helpful in a few cases like this, where we probably could not find any cause in the female and still there is failed fertilization.
madam, your choice, every one of you can give your choice regarding antioxidant usage in male infertility and for how many days. Meenu, madam.
Now actually pharma companies sometimes have made our life much easier. So they come out with the preparations which have the optimum amount of all these antioxidants. So I use that and I give it twice a day, at least for 6 weeks before I go ahead for ICSI for the couple.
Madhuri, madam?
72 days, I mean, at least.
Okay, Samita, 72 days. But what all you look in the combination preparation? Which molecule you look for, and what should be the dosage at least,
I look for CoQ10, at least 300 mg. I mean, for this kind of 5 million, then at least 300 mg of CoQ10.
So
If
basically,
I have to give
any
something, yeah.
use
Yes,
of antioxidants is an empirical treatment in the male. And
Yeah.
when one is starting any antioxidants in the male, one has to counsel the male patient saying that it may help or it may not help you. So we are just giving it on trial basis. It has to be given at least minimally for a period of 3 months before you again examine the patient. And they say vitamin E and vitamin C are the best antioxidants that can be given. But because the dose of vitamin C that is required is very, very high, at times the patients don't take a high dose. So probably one could use CoQ 300, as Samita has already said. But I don't think I use any of the others. And I don't like to use any combinations, because when you combine the drugs, the pharmacokinetics of each of the drug gets altered and therefore should not be used, according to me.
Yeah, another thing, whenever we are giving these antioxidants to the male partner, many a times they think that their counts will become normal and they will have a spontaneous conception. So that also has to be counseled, that we are giving it to get better results with ICSI. You already have low sperm count, you need to go for ICSI, and we are giving you this medication not for a spontaneous conception but to get a better result of ICSI. So I normally tell them that if I take vitamin A, my specs will not go off, but it will just slightly improve the vision. So something
No,
like
but
that.
many a times the patients do come with spontaneous conception. You should not say that, because that's going to reflect bad on you. Because I've had patients, where we've given CoQ for 3 months and the patient afterwards just comes with a spontaneous conception.
That
So I
miracle
think
thing
that should
happens
not be said
everywhere.
to the patient, that you're not going to have a spontaneous
Not,
conception.
yeah, but I'm not giving you for that reason. That's
No,
what
but we should just say that basically it may or may not improve. That's all.
So my next question is, this is a case of severe oligoasteroiderospermia. So in this case,
the last case,
it's
Nilesh.
recommended that we do hormones in such patients, and we check what are the FSH levels, what are the testosterone, estrogen, what is the TE ratio. So use of clomiphene empirically or evidence based. I, of course, Madhuri madam will say evidence based. Definitely, I agree. But in which patients you will use clomiphene citrate as an adjuvant, letrozole as an adjuvant, and or maybe plus minus gonadotropins and HCG. Each one of you can answer this. I can start
I'll
with
answer
Madhuri madam.
last. I'll
Yes.
answer last.
Okay, ma'am. No problem.
Let everybody answer.
Nilesh, if it is a hyper patient where
Yeah.
we have low FSH, low LH, or patient has low testosterone, or patient has been on testosterone, okay, so these patients again have a low FSH because of a negative feedback. So these are the patients who will respond to either we give them gonadotropins or we give them letrozole or even clomiphene by negative feedback to increase the FSH. That is what I would think. So I would probably hypo patients start them on only HCG to increase the testosterone values, intratesticular testosterone. Once it increases, it will improve the spermatogenesis. However, in 2 months' time, if we don't have good results, we can add HMG to them. Twice a week HMG and once a week SCG. Uh, Poor motility, good sperm count, everything is okay. There are some publications to show that if we give them clomiphene citrate 25 milligram daily for 3 months, it improves the motility. And there are also some publications for letrozole and anastrozole, 1 milligram letrozole, 5 milligram per day. But we can take others' opinions as well.
Dr. Shweta, your choice.
Hypo medical management of male infertility, to my knowledge, is effective in hypogonadtrophic hypogonadism male. And other than that, as Madhuri madam said, vitamin C, vitamin E is something which can be tried empirically. And all these theories, I think so, they need more study. This is my take on the management.
Samida, your comments, if any, before I go to Madhuri madam.
The estradiol levels, and if, like, let's say the FSH LH is within normal limits and testosterone is somewhere around 300 ng per dl, and if the testosterone estradiol level is more than 10, I would like to go ahead with clomiphene citrate, and if that is less than 10, I would prefer to go ahead with aromatase inhibitors. So that is usually how I start.
Madhuri madam, your choice regarding
Yes.
adjuvants.
So basically, one must realize that clomiphene citrate will act only if the FSH and LH levels are less than 6. If you have your FSH and LH levels which are more than 6, clomiphene citrate or tamoxifen, either of the two is not going to act and should not be given. If it is hypo wherein you have very low FSH and LH levels, then gonadotropins is your choice, where it's better to combine HMG with HCG, wherein you give HCG thrice a week and you give HMG twice a week. Letrozole should be given when your testosterone and estradiol ratio is altered. And in those patients, letrozole is given. And basically, it's better to give anastrozole in the dose of 1 milligram, which is a better drug in the males as compared to letrozole, which is given 1 milligrams per day for 3 months. And you can see that the testosterone estrogen ratio gets altered. And when we talk about antibiotics and culture, as in my talk I said yesterday also, one has to differentiate between WBCs and immature germ cells, because both of them almost look alike. So many people, just by looking at and seeing a lot of round cells, they just subject the patient to culture or give antibiotics empirically, which should not be done. So we have to stain them, and then we have to really, for me, if I look at a sample, I can make out which is a WBC and I can make out which is a immature germ cell. So I will not, give antibiotics just empirically. So that's also a very important thing. And antioxidants should not be given continuously. So basically, they should be given only for 3 to 6 months, and you have to stop them after 6 months because they have their own side effects, and especially they have side effects on the renal function, and it's known that it can cause renal failure. So basically, no antioxidant should be given for more than 6 months.
Can I make a point here, Nilesh?
Yeah.
Sometimes we get these men who take testosterone injections or patches for low libido. So the libido gets improved, but their fertility gets hampered because the testosterone by negative feedback reduces the spermatogenesis. So we should take that history when they come, sometimes.
No, this is basically in patients who are bodybuilders. I mean, who go to the
Bodybuilders
gym
as
and who are
well.
bodybuilders who take anabolic steroids.
Yes,
Basically, they have erectile and ejaculatory dysfunction, and they also have low sperm count.
So, do I have time for the next case or we conclude?
Don't think so because we have the post test also now.
Okay.
You can wind.
Yeah, sure. So the next case was about thin endometrium. I'm not going into the details of that. So, friends, adjuvants definitely have some role in therapy, but individualization of patient care is very, very important. So, you must have got all those pinpoint or key messages from all the panelists which are there. So small steps in the right direction can turn out to be the biggest step of your life, and this can also change your treatment plans and change the outcomes of your treatment. So I thank my panelists for being there, Madhuri madam, Dr. Meenu madam, Dr. Shweta, and Dr. Samida for being there for such a wonderful panel. And I rest my case. Thank you.
Thank you. Thank you, Nilesh. It was a wonderful panel. Very nice. Very good cases that you have put up for the panel. Thank you very much. So, Nilima, can you put the post-test link? Madhuri madam, can we put the post-test link now?
Yeah. But then we should not give the answers. We'll give the answers tomorrow too.
Tomorrow, yeah.
Yeah.
She's just sent me the questions for the answers, but I'm not seen them. So I'll correct and I'll send it.
Yeah.
So the link has been posted, ma'am.
Yeah, post-test link is there.
Meenu, can I leave my OPD?
Yeah, sure, madam, no problem. So people who have not done the pre-test, it is all right. You can only do the post-test also and submit the form. Okay, so it's all right. Even if you have not done the pre-test, do the post-test. Yesterday, today, and tomorrow's post-test, and then we will take the this thing, average. There are people asking for yesterday's answers. We will put all the answers tomorrow, all 3 days. So, Nilima, have we got all the submissions?
Yes, ma'am.
So, everybody is submitted, no? So, tomorrow everybody should join by 4 o'clock, and all the recordings of all the lectures will be available after 1 week. Also, the people who have registered will get a certificate with 10 ICOG credit points. So tomorrow, all the 3 days results will be declared. Not the results, the correct answers will be declared tomorrow evening. So thank you very much, and thank you, Dr. Shweta, Dr. Samidha, and everyone else.
Thank you, ma'am.
Thank you so much. Thank you.
Thank you, ma'am, for having
Thank
this
you, ma'am. Thank you so
sharing
much.
sessions.
Thank you.
Thanks
Thank
a
you.
lot, ma'am.
Thank you. Thank you, everyone. And
Thank you, ma'am. Thank you
yes,
so
thanks.
much. Yeah.
Thanks. Bye.
Thanks.
Bye. Bye.
Good night.
And see you all tomorrow. Thank you.